quorum present, and I'd like to call the committee back to order. And we have the next witness is Dr. Jefferson, the medical director for the HSA. So bring him in. Good afternoon, Dr. Jefferson, and thanks for taking the time to come down there, because I know that you doctors are like we politicians, don't have anything to do, we're just busy all the time. We just have a few questions for you, not so much in the side of the money side of things or the business side, but more to do with the I know that you're actively and constantly trying to improve and document the quality of care.
Right.
So the last time you were here, we kind of got some commitment from the people around you that they were going to give you some funds.
That's correct.
And we know that those funds would not be represented in these accounts because that was the 2016 account. And that money would be in this year's budget. But we just wanted you to give us an update on the training of particularly the Cayman medical staff up to board certification. How is that going?
Well, thanks, Mr. Chairman, for inviting me, and thanks to the other members of the committee. The training for Caymanian doctors has started, and it is going relatively well. In fact, I am pretty optimistic. I'll give you some details. The Cayman Islands at the Health HSA, well, as you said earlier, one of the things that has been very dear to me and very dear to quite a number of the other members at the hospital is to see young physicians trained up to specialist level. Gone are the days when it was okay to just complete medical school and then just put up a practice somewhere. We're now in the era where you have to be adequately trained. You have to be at that point where the patients are confident that when they see a physician, they're seeing a well-trained physician. So in that regard, we've put in a number of strategies to try and train the Caymanian physicians who have left medical school. We've now at the HSA, there are 2 levels. We bring our young Caymanians back home. They have a choice. Once they're through with medical school, they can decide to go on directly to postgraduate training after they've completed internship and the senior house officer year. Or they could come back to the Cayman Islands, spend 2 years, and then go off to train. The reason we give the second option is because sometimes by coming home, that's the only time they see where the need really exists. And that helps them to make up their mind into what areas they want to go into. And we've found that to be very useful. Right now, we have a total of 6 Caymanians in training at the HSA. 4 are currently in postgraduate training, and each of those, of the 4 at the HSA, there are 2 who obtained scholarship through the Education Council, and then there are 2 others who they're salaried. Well, they're all salaried. In addition to those at the HSA, there are a number of the others abroad. There is at least 6 who are in training overseas right now. There is one young Caymanian who is being trained to be a consultant in obstetrics and gynecology. He has the option of spending his penultimate year at the HSA working in the department to get a feel of the local color, a feel of what is going to be expected to be working with. And also, I've encouraged him to do a subspecialty in an area of obstetrics and gynecology that is going to be of interest and is going to be needed. In addition to that, we have one Caymanian who is doing pathology, which is something that we really need, and she's at University of West Indies. There is another one who is doing microbiology, again at the University of West Indies. And then we have a few others who are either in the UK or in the, or in the US. So the training is going well. Now, there are a number of others to be trained who are waiting to be trained. There are at least four who are at the level now to be trained, and we have put together a program. The Ministry of Health, that is, they've committed them, along with the Ministry of Finance, they've committed to providing funding for the training of these four. Actually, there are five, but four will be going into training next year, and the fifth one will spend another year at the HSA. So I'm very optimistic.
Good. That sounds really well. Some time ago, I know you were working on the introduction of proper medical staff, bylaws, and other regulations. How was the implementation of that going?
Well, right. Thanks for asking, Mr. Chair. The bylaws was written. It was ratified by the board, and also recently we're going into a period of accreditation, and we've recently, that again is one of the passion that I have, the passion of ensuring that policies, procedures, protocols are followed, and also that there's an accreditation. The senior management at the hospital has been focusing on ensuring that we're adequately accredited. Now, this accreditation manager that was recently employed, he has asked prior to complete implementation of the bylaws, just for him to have an overlook, just to overlook and see what's going on. Basically, he's pretty pleased with what the document that's been produced. We've implemented aspects of it with respect to some of the governance areas of healthcare, especially in relation to oversight for the non-HSA physicians, because that require a degree of special gymnastics to ensure that there's proper oversight. So the essential and crucial areas that look into the delivery of quality care has been implemented. The full implementation, I'm hoping, will be done by the time the year is finished. I'm just waiting on a few more words from our manager who is overseeing quality.
And that includes some the ability for medical audits and peer reviews.
Yes. Well, medical audit and peer reviews been going on at the HSA now for some time. In fact, there's different levels of clinical audit that we do. About 4 years ago, we implemented a system where once per month, a group of senior consultants sit around a table and have very frank, painful discussions about healthcare quality. There are several levels. At the first level, if we are concerned about a specific thing that has happened at the hospital, a specific outcome, the medical director will look into it as an individual, and with some degree of expertise, will look at the outcome, look at what was expected, look at the deviation, see how it deviated from what would be the norm based on evidence. Then the medical director will call for a meeting of colleagues relating to the whatever the incident was, and others who may have some expertise. This is on a ad hoc basis. After discussion about this, we normally have a discussion with all the individuals involved, and that again takes place on a ad hoc basis. But every month we have a formal meeting where we do, it's called a clinical review, where we look at all those cases, and it's not just cases that happened at the HSA, but we've opened it to cases that have taken place, some incidents that have taken place in other hospitals or elsewhere. and we discuss it frankly. Behind closed doors, it's not a system of trying to put a blame or anything. And the physicians are told it's a tough meeting. It's a meeting that often ends up with colleagues crying. But at the end of the day, we learn something from it. It's basically an opportunity to see what could have been done differently. Did something go wrong? It's a frank discussion of what could have been done in a different way. And sometimes, it's there's a lot of tears, but it's very useful. So that has always been in place. Now, with this bylaws, it has sort of made it more formalized because no, and by the way, this committee is chaired by a non-HSA physician. And there are 50% of the physicians on the committee are non-HSA physicians. Dr. Meggs is the chairman, and we have private sector physicians and public sector physicians. And of recent times, we've been having quite a lot of participation from some of the other hospitals. We've had all of the most recent meetings, we've had persons from other hospitals participating.
Good. That's all good and right there. Early on, the committee in questioning some of the staff and adequacy or inadequacy thereof raised some concerns about particularly the clinicians working 12-hour shifts, i.e. the nurses and stuff. Are you comfortable that 12 hours is not
Yeah.
a tough call on particularly
On the nurses.
in the environment that we're in, where a lot of those nurses have home obligations, they have family, so they can't. The 4 days off are not really days off. They're only,
Right. And Mr. Chair, that's a very good point. The medical profession has gone through a number of evolutions. In fact, there was a time when shifts were 8-hour shifts. And then, and this is now speaking internationally, a number of places, like for example, when I was in the UK, they moved to 12-hour shifts. So it was you work for 4 days and then 3 days off, and then you work another 4 days and 3 days off, and and that's how it was. So from the nursing perspective, they had moved from 8 hours to 12 hours, and today, internationally, there are still a number of facilities that have 12 hours, followed by, and some others have just 8 hours. At the HSA, for a good time now, we've been doing 12-hour shifts, and we've not really had much of a problem or complaint. They've been, and not just for the nurses, by the way, but also the paramedics. They also do 12-hour shifts. The physicians, traditionally, we just work. Basically, we've been known to go on beyond 12 hours, 14, 16, 24 hours. But even the physicians, there are some specialties where there's no a move to change that. I remember about 4 years ago, I was in the UK and had a meeting to change the working hours for anesthetist from 24 hours to 12. And there were a group of senior consultants who were protesting the move because they are accustomed to doing 24/48. From the physician's perspective, I've not had any complaint. From the nursing perspective, I must say I really don't have much reason to be very concerned about the 12 hours.
Okay. Mr. Bush?
Now, Mr. Jefferson, I need your guidance through you, Mr. Chairman. I am going to give you the scenario. Like I told one of your previous people, over the last year or two, I have, as a MLA, I have to go to the hospital often to look for friends, constituents, etc. And I said this earlier on to one of the previous HSA people that came here. Paper charting versus computer charting. This is one nurse now. Why do nurses have to complete any paper charting if they are documenting via computer everything that they've done? Waste of time, paper, and it's another stressor on us nurses. Now here's another nurse. It's standard that working 12-hour shifts. The difference is since I've left Cayman, I'm now in the US, we were required to work 3 days a week and 4 days off. In Cayman, nurses work 4 days a week, a lot of times, and they usually work longer than 12 hours because they don't have a good system for charting on patients. Here it comes up again. Mm-hmm. So they stay after the shift trying to chart everything. How they do it? Nurse assignments should be made prior to every shift, allowing for a smooth transition when it's time for change of shift. Nurses can then report on their assigned patients and start their day instead of waiting for the charge nurse to make an assignment after receiving reports. You understand?
Yeah.
Okay. And here's a third nurse. What makes it difficult is I don't want to throw the nursing assistants under the bus, but they need to do a little more because they should be doing all the patient hygiene, care, and help, and then with their meals if necessary and so forth. Nurses barely have enough time to do medications, vital signs, and other care needed for patients on top of taking new orders from doctors, getting admissions and discharging patients, helping with procedures on their patients, taking them down to surgery, and the list continues. Those are some
Concerns.
Thank you. So you shake your head, I'll say no more.
Yeah. Mr. Chair, through you, I'll respond to this to the extent that I'm able to. Unfortunately, the management of the nurses is overseen by another senior manager. But I am intimately really, involved to some extent because I work with these nurses as well. I must say that we are fortunate in the Cayman Islands in general that we have some of the most qualified nurses. We have some of the absolute best nurses here, and they take their job very seriously. When we recruit nurses, even though, again, I'm not the person doing the recruiting, but I happen to know that there are certain things that are taken into consideration when the nurses are recruited. In fact, they must be able to adequately look after the patients with a degree of professionalism. And we are seeing this in some areas more than others, but by and large, it's very professionally done. The move from paper charts to electronic medical records has improved significantly accountability. It has improved significantly how we are able to follow patients. It's much better for auditing, and it is much better for the physicians to have everything in one place by the click of a button or mouse. But with this comes some disadvantages. One disadvantage is that sometimes, depending on the particular individual, it takes a while longer to be able to put all the details, the information into the chart. And it is not uncommon for clinicians, not just nurses. It's not uncommon for physicians after a clinic is finished to stay back and put the notes in. We audit to ensure that the notes are there because if it is not recorded, it never happened. And for us to be able to go back and see what's been going on with the patients, we have it done electronically. And also, I've heard some nurses say that they've had to, stay back, just like the physicians do, to put the notes in. And so this definitely increases the amount of time that they're there. Not too sure, Mr. Chair, what the answer is as it relates to the electronic medical records beyond providing the nurses with more tools to be able to adequately do this. To the question of changeover, it's one of the things that has for some time been an issue in a number of organizations. The nurse completes the shift, and new shift and nurses come on, and then a period of time is spent familiarizing the nurses with the ones that were there before. There has been some concerns raised that the changeover should probably have taken place rather than at the end of the shift, which requires for the new nurses coming on to stay for an additional 30 minutes. It should probably take place 30 minutes before the end of the first shift. Again, I am not too sure how best to work that out. I think I would probably have discussions with the chief nursing officer to see how well that could be implemented. But I take your point, and I've written the concerns. I'll take them to the chief nursing officer to see how best she can address those.
Thank you very much, Mr. Chairman and Dr. Jefferson. First of all, I just want to thank you for coming here today. Now, from an economic standpoint, we're normally concerned with three areas of healthcare, namely access, cost, and quality. The access and the cost is normally something that's more driven by the political directorate, but the quality of care is something that is more on the medical side, to which none of us in the political field, at least, that I'm aware of, could more, I guess, get an idea on the quality. One of the things I'm just reading from page number 2 of the Ensuring Quality Healthcare and the Health and Population Report that was completed by the Auditor General. One of the areas, the second to last paragraph, it says, data from the 2010 census about the incidence of some diagnosed illness shows, for example, that the incidence of heart conditions is nearly 6 times greater among the Caymanian population, and that of diabetes is 3 times higher. One of the things I'm more, I guess, concerned about, and this is more from a long-term strategic standpoint, is what do you think we can do better in terms of preventative care? Because clearly, if heart conditions are definitely going to be an issue, then looking at the future of the HSA, which is still responsible for the overall provision of healthcare in the Cayman Islands, regardless of whatever private institutions may offer, in terms of 1, the number of cardiologists, 2, the type of doctors that you have that deals with diabetes. I'm sorry, I'm not familiar with those type of doctors. But then from a long-term standpoint, in terms of in your role as the medical director, what is it that we're doing now? Are we on the path to make sure that using the information that we do have, that we have the right structure in place or the right complement of staff in place? Because I understand recently that I think we went out and we may have gotten, I think, maybe some doctors from elsewhere. But I just want some comfort level that based on the trend in what we have here in the Cayman Islands, that the HSA medical staff is equipped to deal with the cases we have today and potentially the cases that we may have tomorrow. And in your position, if that is the case, that's good. But if that's not the case, what do you think we need to do? Thanks.
Very good question. Thank you very much. And through you, Mr. Chair, it's really, I do, I like the question. Actually, it speaks to population health, and it speaks to the population health of the country in general and where we are now and where we should be. And you are correct. As it is now, the cardiovascular disease is one of the major issues in the Cayman Islands, and it's right up there with cancers and with some of the endocrinology issues, diabetes, hypertension. Hypertension actually is mostly cardiovascular. So myocardial infarction, strokes, those things that are cardiovascular related is very high. The statistics has shown that we as a country are probably similar in the profile, the disease profile pattern, as in some of the other countries within the Caribbean. So we're in the Cayman Islands, not significantly different to what we see in the other Caribbean islands. It therefore means that since we have such a large population of patients with cardiovascular abnormalities, diabetes, and other endocrine abnormalities, cancers, that our focus really should be from the primary healthcare preventing these. So primary prevention and focus on building the primary care is one aspect of focus. The other aspect is to ensure that when you do get these patients who are unfortunate enough to have gotten these diseases, then the secondary and tertiary care is available to support and to make them better. I will speak to the primary care. There are a number of initiatives. You may have heard about one where we are trying now. Let us say the Ministry of Health has actually approved for the Public Health Department to have a mechanism for registering and tracking and identifying those patients who are at risk. So some funding was made available for that through from the Ministry of Health through the Public Health Department. So the first thing we need to do is to know who these patients are, where are they living, what are they doing, what's going on with them, and to whom are their family members? What are the risk factors that they're exposed to? So that is, to that end, the Medical Officer of Health and we've decided to partner with the other facilities on the island to get their figures. So it's not just the HSA figures from the primary care perspective, but what's happening at the doctor's hospital, what's happening at the health city, what's happening at some of the private offices. So what we've done is had lunch meetings, and we've gotten input from the private sector physicians to get a mechanism of getting their figures. And also, we've brainstormed implementing some of the more evidence-based strategies that are already being well established in a number of other places to reduce the complications associated with diabetes, hypertension, cardiovascular abnormalities, and to decrease the risk factors that's leading to cancers. So that's from the primary healthcare perspective. From the secondary healthcare perspective, we at the HSA have a responsibility to ensure that we have physicians, and not just physician support staff, to care for those persons who do come with these diseases. So to the aspect of the diabetes and patients suffering from diabetes, we have expanded our family medicine area. So we have now expanded urgent care so that there's more access to quality family physicians. But not only that, we have partnered with the University of the West Indies to train family physicians. So I made an initiative with the University of the West Indies to have the HSA certified as a UWI affiliate facility where family physicians could be trained through partially at the University of the West Indies and partially at the HSA. So now we have 6 of these physicians in that program in preparation for the family medicine, for the expanding family medicine availability of family physicians. In addition to that, we need specialists. We need more internists, and we have expanded the internal medicine cadre so that there are more internists available for these patients with diabetes, hypertension, that sort of thing. As it relates to cancer, that was one of our difficulty. We had a long time we were unable to recruit for oncologists and hematologists. I must say that we've been fortunate that we've now had a very well-renowned oncologist sign on and will start with us in a few months. So that will address the oncology. I am pretty hopeful there are mechanisms that need to be put in place to better manage the population health of Cayman. I've just gotten back from an international conference where we had a number of representatives from all over the world. And when I look at what's happening here compared to what's happening elsewhere, actually, I sat in a meeting and I listened to the CEO from another health services authority in the region. And when she gave her figures, I felt a little bit better. I mean, I was not completely comforted because our figures in terms of chronic health is not very good either. But I was comforted in the fact that we were only, as a percentage, a third, seeing a third of what she was presenting. And they have as equal amount of resource, if not more. But for some strange reason, their outcomes was not as good as ours for whatever reason. And so, whereas it's not perfect, we have been expanding in a number of different areas to ensure that we have adequate amount of physicians to satisfy what we have here on the island, what we see.
Thank you, Dr. Jefferson. In terms of home visit, do you guys actually do do your doctors also do home visits?
I am pretty sure they do. Unfortunately, that falls under the medical officer of health.
They do through they can help you with that because I'm constantly pressuring them for nausea.
Oh.
But they do it through the district clinics under the public health aspect of it.
Okay.
Right.
From the district clinics, and they would also be doing the same thing.
No, the reason why I ask, I'm just looking at the compendium of statistics. When it was in 2015, it was roughly a total of 6,500. And in 2016, it jumped up to 7,628. So more than 1,000 visits. So I think that's actually one of the stats that actually moving in the right direction. The next question now, Dr. Jefferson, if you don't mind. In your opinion, in your assessment, what do you think ultimately would be the right model, or what success would look like for the Cayman Islands in, say, the next 5 years? Like, what path do you think we should be going down or should be embarking on to ensure that we have a healthy population?
Right. Very good. Through you, Mr. Chair, one has to set out a plan that speaks to quality. It shouldn't. One of the focus in the Cayman Islands has got to be quality healthcare. Quality, like you say, cost effectiveness, access to care. And the reason why I chose quality first, because that's my own burning pet peeve. I think unless you have a way of measuring what's been delivered, and unless you have a way of reporting what's been delivered, unless you have a central body that's responsible for managing the data of what's been delivered, then you cannot truly, confidently say that you are seeing quality care. So that's the first thing. First aspect in my mind is to establish some quality standards that's adhered to and reported. The second thing, like I alluded to earlier, is the expansion of the primary care and preventative medicine. A focus on ensuring that there is adequate access to care at the primary level throughout the island. Strategically placed, I mean, we have throughout the districts, the district clinics, which forms the adequate nidus for building on and expanding primary care. I mean, we're having good primary care going there, and I can confidently say we have good primary care because I've been exposed to what obtains elsewhere. And comparatively, we have very good primary care, but there is always that place for expansion of greater level of primary care. So that would be the second thing that I would want to see happen. The third thing, again, as I mentioned, would be for there to be, within the secondary and tertiary level, adequate access to care, either be at the government facility or the private facility. But a coming together of all the providers to strategize as to how best to ensure that the patients will have access to care. Doesn't matter if it is within the private sector or within the public sector, but there must be identified. I mean, we send a lot of patients off island, and we still continue to do that. And we probably will always be sending patients abroad because it's some of the higher end specialist service we will definitely not be able to provide on the Cayman Islands. But if we can move to a strategy that keeps more patients at home, that would be ideal. That's not easy because it's not just the having of the facility here, but within the Cayman Islands, there's been a culture of wanting to go North America because if it is done in North America, it's done better. And sometimes, in fact, often that is so absolutely wrong. I have seen where I have invested in getting the best experts in a particular field right here in Cayman, the best experts that God has helped me to recruit from Europe. And they're here, and I've had patients asking me for referral to go overseas to be seen by some specialists who are substandard to the ones that are right here at home. So that, again, would be something that I'd want to see, some sort of education program where patients are taught that, listen, this thing of going to North America to get care is not necessary anymore in a number of respects. Yeah, so that would be the second thing. The third thing, Mr. Chair started by talking about the sustainability, even though he didn't call it sustainability. Sustainability of healthcare through ensuring that we have adequate staff trained to provide the care that's going to be needed. I am pleased and I am sort of happy because I've seen over the 20 years or so that I've been involved in healthcare here, I've seen a significant change where now we have a number of locals providing the healthcare that was previously provided by persons from abroad. I was this evening, just prior to this meeting, looking and see that we have at the HSA right now, between the Caymanian physicians, we have 30-something% of the Caymanians of the physicians are Caymanians. Actually, 38%. If you count those with permanent residence as well, it would be 57%, which is much better than when I arrived several decades ago. But what I've noticed also is that there are so many young Caymanians coming up. And with this provision of funding that's been made available through the Health Ministry and the Ministry of Finance, I see even more Caymanians being trained. Right now, as we speak, there are 17 young Caymanians. I have a roster of Caymanians, and I have 38 Caymanian physicians that are out there. 17 of them will finish their postgraduate training within the next year to 4 years. And that is something that is wonderful. There are 7 already trained, finished, who I've been trying to massage to come back home. And so, to your question, it is multiple things that would make healthcare perfect in Cayman. It's not as bad as some people think it is right now, and I can tell you confidently that we're moving in the right direction. With the advent of Health City, that has provided a new dimension, and it has afforded us the opportunity to access another level of cardiac care for patients that would normally have had to send abroad. But we are on the path, in my mind, we're on the right path. Not there yet, and it'll probably take a while to get there, but I'm hopeful.
Dr. Jefferson, sir, Mr. Chairman, through you, sir. I want to thanks for that answer.
I want to follow up on somebody.
Yeah, and the reason. No, see, along the same thing. The reason I'm kind of happy to hear that is that I have long held the belief, and just my personal belief, that there's some aspect of society that can't be achieved or done through competition, but through cooperation. And I'm kind of hearing that. And one of the things I would like before this you wrap up your testimony is to just explain to this committee and to the listening public is, in your opinion, and this will just be your opinion, from a structural standpoint within the HSA. Because one of the things, as I had mentioned before, is that we're looking at access, we're looking at cost, we're looking at the quality. From that standpoint, when we start looking at the cost and the direction of the cost, I'm seeing a model where eventually that it is going to be a bigger burden if we don't deal with it or arrest it from that standpoint.
Right.
And from that standpoint, I mean, and this is something, that part we'll have to deal with at a political level. But in your humble opinion, in the different places that you have worked and different seminars that you would have been to, what do you see as being ultimately the role of the HSA within the Cayman Islands as a whole? And where would you would like to see it as an organization within, say, the next 5 years? Because one of the things that I find that's really missing and we have not received that today is the strategic direction of that organization. Now, I know this question may be a little bit slight off, so I know the chairman had a question based on what you said previously. But I want to put that one there while I still remember it, but I will yield to the chairman for his follow-up in what you had said before.
Just to Dr. Jefferson, are you receiving any, are you aware, is there any pressure being put on the Health Services Authority to reduce services for financial reasons?
To reduce service, not that I'm, Mr. Chair, not that I'm aware of.
Okay.
Not that I'm aware
That's
of.
okay.
No.
Start looking. Another question is role of the Chief Medical Officer. A lot of the things that you just talked about, I see as being a role of the Chief Medical Officer, who should be in the ministry, who should be the person that advises the ministry on public policy, which you need to overarch all the things that you're trying to do. Because unless you have the public policy at that level, which the board is supposed to take then and implement through the HSA, it's going to be very difficult for you to achieve the things that you need to achieve.
That's correct.
So, is there any likelihood that the position of Chief Medical Officer within the HSA will be transferred to the ministry so that it can be more of a policy directing and engineering stuff?
Thanks for asking, Mr. Chair. I will answer your questions. I remember it's fresh in my mind, and then I'll move on to the next member's question. With respect to the chief medical officer, the chief medical officer within any country, within the CARICOM region, has a very important strategic role. The chief medical officer is responsible to survey what's been happening with respect to healthcare in the country to which he is appointed. And his responsibility is to ensure that quality care is delivered on behalf of the people that he represents. So it is more a strategic position, and he scans on behalf of the Ministry of Health and ensure that there is cost-effective healthcare being provided. So the healthcare is cost-effective, it is relevant, it should be evidence-based, and he or she has a significant regulatory responsibility. So one is provisioning and the other one is regulation. And advice, strategic advice with respect to policies, policy direction, and is the chief technocrat, the person with the technical know-how as it relates to advising the relevant ministry. As such, it is ideal for the chief medical officer to operate from the perspective of being in the ministry itself. Currently, the Ministry of Health, recognizing the need to have this person there, they have actually now put in place plans to move that office to the in the Ministry of Health so that they can operate on that policy strategic level.
That's music to my ears.
Right.
Because just to follow on, then we can get the necessary policy on the kind of physicians that we should be licensing.
Exactly.
Because what we're having now is we're accommodating anybody who walks through the front door, and we're licensing them in that specialty. So some specialties are totally overprescribed, right? And other specialties are underprescribed or don't exist. But the policy and the direction for that regulatory function must come from the CMO within the ministry down to the board, who then, and the demand for the kind of specialists that you need to be generated at your operational level, looking at the indices of disease, et cetera, and saying we need to find some people to license in this specialty.
Yeah, Mr. Chair, that's correct. So that chief medical officer has a responsibility to see where the needs are, see where there's a bigger bang for the buck, and to make an input and advise the ministry to say this is where the funds should go. And so I am definitely in agreement with that. With respect to the question concerning collaboration, and that is the key for the healthcare. The Cayman Islands is small. We're under 60 million. We're just under 60,000 people, and as such, we will not succeed if we do it individually, unless we find a way to collaborate. We will be having several ducks running in different directions. We have to find a way to bring everybody to the table and say, okay, you do so and so very well. Let us see how you could enhance that. We're going to ask you to focus on this because you're doing this very well. And I see us having an opportunity for finding out where the niche is, where this particular team should be encouraged to focus on enhancing what's happening in this particular area. There's no point in competing in this small setting, because what you find, there really are no winners in competition. Actually, there aren't, because what you find is with stiff competitive framework comes an increase in the total cost of care delivery. So what you really ought to be doing is looking at what is it that we do well and do it well. The HSA will always have a place, will always have a function. The HSA is the country's, well, let me be...
It's the only sustainable thing that you have.
Exactly. It's the country's sustainable avenue for delivery of care. And therefore, it is important that the HSA focuses on ensuring adequate primary care, adequate secondary care, and the tertiary care that HSA does well to continue to do that. I mean, there are some areas that HSA is the leader and will always be the leader in tertiary care levels. I mean, I could, I will just tell you one. One of them is orthopedic surgery. We have 3 orthopedic surgeons who, together as a team, can do magnificent job better than anywhere in North America or anywhere else. So, the thing is that we have some tertiary care that is fantastic if only people knew about it. But then there's no need to compete. There's no need, for example, for us at the HSA to expand into very advanced cardiothoracic care because we have a cardiothoracic facility here. Now, if we see where this cardiothoracic facility is not going to be sustainable, then it behoves us to ensure that we put mechanism in place in a government facility to mitigate any problem that could arise with not having that facility anymore. We have a responsibility as the sustainable government facility to scan healthcare on the island and to see where the deficits are, where the defects are, and to see if we can patch it ourselves, or if we can encourage others within the private sector to patch it, or to make sure that there is, that service is available. So, to your question, I see a need, I see a value in collaboration. But at the same time, we have to collaborate smartly. We have to ensure that the facility that we have is maintained, because it's the sustainable provider of healthcare for the people.
And the other thing that you don't have, because you don't have the necessary public health policies, you don't have any ability now to regulate what some of these other private sectors agencies are doing, which may be outside the original license, but they see it as bringing a few extra dollars in the door, and it's a temporary thing. And if you abrogate your responsibility, then the country's going to be left without it if it fails on a financial front somewhere else.
That's correct, Mr. Chair.
But do you have any idea when we are likely to get the public health law revised?
Revised.
Because we had a revision in 2002, but that was done by the legal people,
Right.
in terms of incorporating all of the amendments. The last amendment that was made to this law in relation to the public's health, I think, was made in 1990.
Right.
And this law needs to seriously be reviewed and updated. And in here is where we need to frame that policy framework, oversight, monitoring, et cetera,
Fantastic.
and let the HSA be the implementer of what the public health law generates in policy.
Thank you. Thank you, Mr.
And
Chair.
everybody else must fit into that mold.
Thank you, Mr. Chair. To the question of when it's going to be amended, I'm not too sure, but there are some aspects of it that need amending. And as you rightfully say, one of my concern is that there is a need for that public health regulatory body that oversees quality from a number of perspectives. But that is something that I'm hoping will in a very near future, we'll be able to achieve.
Mr. Austin?
Thank you, Mr. Chairman. Thank you, sir. In terms of enhancing the training and development for both the existing medical personnel as well as to enhance the further development of new talent, creating a Caymanization, if you will, of the medical profession. I think, again, to your point, we can be proud of our collaboration vis-a-vis the development of the School of Nursing at UCCI.
Right.
Likewise, the various programs being offered at Health City. And I agree with you that competing is not in our best interest as it is collaborating. However, some medical professionals have argued that as a country we need to do more to develop Caymanian medical personnel by offering them exposure outside of the island. Some have stated that as a country we need a larger population base in order to build competence, as medicine is a profession involving a large experimental apprenticeship component. I wonder if you agree with that, and also do you believe that there would be a benefit in Cayman to offer, and forgive me if the term is incorrect, but secondment, similar to what the law profession does to allow its participants, practitioners, to become better lawyers. Do you believe there's an opportunity for us in the Cayman Islands to offer a similar exposure opportunity for Caymanian medical personnel, whether it be University of West Indies or whatever, to build that competence so that we can, in turn, translate that into confidence to the Caymanian public?
Thank you very much. Through you, Mr. Chair, that's a very good observation. See, you cannot have physicians who are trained and remain in Cayman providing the quality of care that is expected. The population is too small. The pathology that you see is too limited. The experience and exposure is just not there. So as it is now, it is mandatory as it is now for physicians who were trained abroad, who have returned as young physicians, it's mandatory for them to go back before they're fully registered. They have to go back to a high volume center to do what's called a SHO year, the Senior House Officers year. And that's not optional. So all of the physicians who are trained, wherever they're trained, we allow them to come home for a year. Thereafter, they have to go back to a high volume institution that is accredited by the university, either the University of the West Indies or a large university hospital facility anywhere. So that's one thing. The other aspect of it has to do with postgraduate training. We do not, except for the family medicine students, we do not provide postgraduate training here. They have to go on to North America, Europe, or Jamaica. The only exception is those doctors doing their doctorate in family medicine, which is, I explained earlier, I negotiated and arranged along with University of the West Indies, and that is a strategic move. But even these doctors have to go back to Jamaica, to the University of the West Indies or to Kingston Public Hospital to be exposed to a larger volume of a greater pathology. And so we recognize, and that was a struggle because we've had some doctors who've been resisting this and who've fought, not understanding that if you don't know what you don't know, then you're fool. And my thing is, he who knows not what he knows that he knows not is a fool. And you have physicians who think that they know it, they have it, they finished medical school, and so they're no doctors, and they're wrong. I mean, I've been a doctor almost 30 years, and I still know that there's a lot of things that I don't know. And even at my level, I go away from time to time. People complain, oh, Dr. Jeff is always gone. But you know what? It's important that I go. Because even at my level, I have to ensure that I am keeping up to date with the top evidence-based medicine. I have to know what's new in my field. I'm an intensive care specialist, and that's a field that changes. I'm an anesthesiologist as well and a pain specialist. It changes. And what I learned 10 years ago, 10 years later, there's newer technology, newer technique, better outcome. So for those physicians who resist the move, fortunately as it is now, they have no choice. And so I'm very pleased you asked that question because there is definitely the need to ensure that the physicians that come back to the Cayman Islands are physicians who are adequately exposed.
Some couple of years ago, Dr. Neela Pantan, who I will declare is a schoolmate of mine, a personal friend, volunteered and offered to help Caymanians in the Canadian system, and he has never gotten a response. Right. Could I invite you to contact him, because I know that he is more than willing, and he, of course, he has his full professional status now, and I think it's the University of Vancouver, one of them, and is a full consultant. Yes. And he would be, nothing would please him more than being able to help train some of the Caymanians in the postgraduate course. And as you would be aware, a lot of the Caribbean countries have arrangements with the Canadian government, and they pay a little stipend to the people and accommodations, and they get top-notch training. So I would invite you to contact him, because I spoke to him recently, and he's still very much interested.
Thank you. Thank you for that, Mr. Chair.
Through you, Mr. Chairman. Just my final question, Dr. Jefferson. Just out of curiosity, it appears that with regards to the quality of healthcare, that at least you guys are switched on in that regard. One of the things that we have been concerned with has been pretty much the inefficiencies within the HSA. So, as a person who's ultimately charged in terms of the task of carrying out the primary function of the hospital, which is to take care of people. In your humble opinion, doctor, what if there were three things that you could get rid of, you would get rid of? And if there are three things that you could do, that you would do, that you think would make the HSA a better place.
Okay, sir. Three things if I could get rid of. Right.
Listen, doctor, I mean, ultimately, as I said earlier this morning, there are some things, and you can tell, I guess, by even the questions from my colleagues and everyone else, that this is something that we are determined not to play politics with. And our goal at the end of the day, regardless of how many other hospitals are out there, the HSA is still the primary caregiver and still tasked with carrying out the primary functions of delivering health care in the Cayman Islands. So yes, there may be other specialists and everything else, but at the end of the day, this is still something that the people of this country still has a responsibility to ensure that is there. You know, so from that standpoint, and this is the reason why I recognize that, you know, you may, as they would say, step on somebody to con, depends on what the answer may be, but ultimately, for where the public is concerned, and I'm going to say this, is that your testimony today of all the witnesses we have had has been the first that has given me some level of optimism and confidence with what's going on in the HSA. I'm going to put it out there. And from that standpoint, you know, I mean, I'd be curious to know, having working there and everything else, because one of the things that is missing is that we spend more time trying to defend the system as opposed to what can be fixed with the system. And like I said, there are some things that has to be done at a political level, and there are some things that will have to be done by you guys in that profession. But from our standpoint, especially with budget around the corner and everything else, because we're going to go fight to make sure that healthcare and education get money. We'll be fighting for those. Right. But at the same time, we need to understand what it is that we're also will be fighting for. And as you said, it will require some level of public education, which the members of this legislative body is really tasked with, because we are ultimately the link between the public and the government services that are there. So the three things that you would think would make it more efficient, if that's a better choice of words, and then the three things that you think we basically need to stop doing.
Right. I will speak about the efficiency first. Things that would make it more efficient. One of the primary thing in my mind is in physician involvement. For some strange reason, I mean, we have some very, very, very good physicians. In fact, we have some of the very best physicians. So I don't get a lot of complaint about my physician's credentials or the work they do, because we are fortunate, we're very blessed. And I could expand on that, but in the interest of time, I won't. In 2012, I invited a group of chief medical officers. I was the chief medical officer hosting a conference here in the Cayman Islands, and we had 17 chief medical officers who came to participate. I asked for an informal assessment of our health system based on certain criteria that I laid out. And one of the criteria was to look at our physicians and what our physicians were doing. And those chief medical officers were very complimentary, they gave glowing reviews concerning our physicians. So the first thing is to get them more involved in the decision-making process, because for several years they've remained on the periphery of several of the decisions, and the question is not necessarily, there's no blame as it relates to administration. It's just that we need to have the physicians recognize that they themselves have a role to play and be encouraged to get more involved in what's happening. So that would be one of the things that I would recommend. Another thing that I would recommend is education of the population, that right here in the Cayman Islands, you have good health care. There are stigmas and unfair stigmas relating to the HSA for some strange reason, not too sure how historically that has happened. But there is a need for educating the population to say, hey, the care here is good. And I've had patients who have said, I've been living in Cayman Islands for several years, And I've come to the HSA for the first time, not realizing that you guys provide such wonderful care. So that would be the second thing. The third thing I mentioned earlier has to do with a more coming together of the facilities that provide healthcare on Ireland and have a think tank of experts who could sit together and say, how do we go forward? We've had this in the form of, the ministry hosted a group of persons to put the strategic plan 2012-2017 together. But going beyond that, I'm now talking about within the clinicians themselves getting together and say, how as a group, how can we collaborate? We've actually started moving in that direction. Now we're having joint meetings between our physicians and the physicians at Health City and the physicians and some other physicians in the private sector. And that is doing quite well. So those would be three things that I would want to see done better. And of the three, the one that I'm more passionate about is physician involvement in healthcare delivery and in the decision-making process. What would I want to see done differently and changed? There has been an emphasis in cost effectiveness, and cost effectiveness is a little bit different from cost efficiency. We all need finances in order to ensure that we deliver the care that we ought to deliver. But sometimes if the focus becomes too much on finance, you just lose the plot, because you will always lose something at the expense of finance. And I'm not saying that it is not crucial. We have to be fiscally responsible. But health is a merit good, just as education is a merit good. And you will not get necessarily fiscal return, financial return in its direct form, but you get it in an indirect form. So whereas there is the direct benefit of having the cash coming with seeing the patient, there is so much indirect benefit from ensuring you have a population that's healthy, and that doesn't necessarily translate to having the direct funds coming. So I would want to see a little bit less emphasis placed on having the perfect financials. So that would be one of my things. I think as it relates to there's another aspect of the care that has caused me some concern, and it really has to do with persons who don't fully understand what it is that goes on in the HSA making decisions. And it's sometimes it's a problem, because unless you have a full understanding of the dynamics and all of the various parts that are operating, it is difficult for you to make a decision on behalf of the staff, of the organization. The organization needs to spend a little time understanding their role and function, but at the same time has to be given the leeway to make the decisions, because they're the one that is intimately involved with what's going on. And so that would be my second thing, where I'd love for there to be more autonomy in the decision-making process from that perspective. The third thing, I will think about it and I'll get back to you, Mr. Chair. I have more than three, I can guarantee you, but it's probably our best to stop there.
No, that's good. No, Dr. Jefferson, I really want to thank you today for taking my questions. You're giving me a sense of optimism and a sense of hope. And the thing about it is, as you said, when we started out, we have said to every person that testified before you is that we took a balanced scorecard approach. So we are in agreement with you where we're not just looking at the financial performance. We want to look at the processes. We want to look at your controls, but we also want to look at your ability to do new stuff, the ability to innovate. And ultimately, as you said, I mean, I can tell you, we do not have the population to realistically sustain and the hospital or the healthcare that we have, much less having 2 more hospitals. Let's be realistic. And at some point, we have to, as a country and as a people, have to ask the question, do we see healthcare as a benefit or as a right? If it is a benefit, that's one road we go down. But if it's a right, then we have to revisit the way in which we look at it. And I think ultimately, that is a conversation that we need to have at a national level, and that is something more for the political directorate to deal with. But I just want to say thanks very much for your candid response, and I yield, Mr. Chairman.
Mr. Chair, there's just one other thing that I had not mentioned earlier, if I may. Space limits the HSA. And that's one of the challenges that we have. You know, I mean, there's so much that could be done better if only we had the space to do it. It's a challenge that I'm not too sure how to address, but it's a challenge that needs urgent attention. We're limited, we're locked in where we are, and we do the best we can with the space that we have. But the staff identifies the problem, the patients who come in identify the problem, and so much more could be done had we had the space in which to do it. You know, programs that we want to implement. I don't even bother to even write about these, because where am I going to put these programs? You know, we just don't have the space there.
I don't want to say, I told you so. But that was the whole idea behind the Dr. Horton Memorial Hospital and 10 acres of land on a separate site, specifically to allow for this kind of expansion, for the kind of needs you're talking about now. And unfortunately, the country is now beginning to see the folly in that decision in 1993. But that's water under the bridge. We have to address it now. But I will agree with you that it is urgent. And the troubling thing is that nobody seems to be talking about it. So you'll be hearing more about it in the future. Thank you very much for your time, sir. Appreciate it very much.
Sir,
I'm sorry.
Mr. Jefferson, through you, Mr. Chairman. Well, Mr. Harris covered some of it, but I want to break it down for the public, because then it comes into an answer that you just gave. A young Caymanian wants to be a doctor, passes all his prerequisite high school stuff, he goes off to medical school. It's 5 years.
Right.
Then, going back to what you said, which the public should understand that, because there are forces looking to circumvent this.
Right.
Then they have to, if they come back home for a year, then they'll go to UA, something like that. And the reason for that is, in Cayman, you may see, if you're in the emergency, you may see a gunshot, a chop, a broken arm, a broken leg. But if you go to if you go to the west, up in Jamaica to a GP, or what you call it?
To the emergency room, to the
KHPH. You'll see 25 chops, 50 shots,
Exactly.
and various stuff. And that gives you then the practice. Instead of only doing 4 or 5, you're doing 100 a day or whatever.
That's correct.
That's correct what you're trying to get at.
That's correct.
I want the public to understand that. Now, where does the specialization come in? Do you do that first, or when you finish your 5, can you do your specialization then?
No. After you finish your 5, you have to go on now to doing what's called an internship.
Internship.
Then after the internship, you have to
And
do...
how long must the internship be?
An internship is 2 years, but it's split into two... It's 2 years, but it's split into 2 distinct areas. The first year there's a mandatory 4 specialties that you have to rotate through: internal medicine, obstetrics and gynecology, pediatrics, and general surgery.
So an individual coming back will have to rotate through all of them.
Has to do all of those.
Beautiful.
That's the first year. The second year of the internship is what's called that's the year where you now do your SHO in the area.
Forget the abbreviations. The public don't understand.
SHO, Senior House Officers Year. So
Thank
that's
you.
the second year. And that second year of SHO, as Senior House Officer, you now focus on what you are planning to do your specialization in.
Correct.
So if you think you're going to be becoming a general surgeon, then that SHO year is spent doing general surgery, or something similar to general surgery that gives you the skills that would be useful as a general surgeon.
Then that individual will have to go off.
That person has to go off.
Correct.
Not in the Cayman Islands. We don't allow SHO, the Senior House Officer year,
Once
in the Cayman
again,
Islands again.
there's not enough subjects here
That's
to
correct.
give you the expertise.
That's correct.
Now, so when we're giving our young Caymanians scholarships, it should not be 5 years then turn them loose. Do you agree?
Oh, yes, yes, yes. of
Okay,
course.
beautiful. Second thing is, scholarships, do you feel, in your professional opinion, that the scholarships for medicine should be run through you guys instead of through the education department? And make me tell you why I'm asking that. A young man sat in this chair right here in youth parliament and was the premier in youth parliament. He's back now and is looking stuff. He went off and did some time at Michigan State University or somewhere up in the States.
Right.
I know 4 young people who are sitting down, waiting, and some of them have had to go to St. George's, which I understand is not the best of places,
Right.
talking to people around the world. Do you feel it would be better for education scholarships, for medical scholarships, for you all to be given the money and for you all to deal with this? What's your opinion on that?
Right.
Because you understand medicine, you understand what these people want to study, whereas the people at the education ministry, they're not putting them down, they're doing a decent job, but they don't know nothing about medicine.
Right.
Whereas you guys do. When you said earlier on about people outside making decisions that don't understand the true ramifications and the full scope, here it comes back to that again. What's your opinion? What's your professional opinion on that?
Right. Through you, Mr. Chair, as it is now in the Cayman Islands, as you've said, the education department provides a scholarship. Now, the needs, that which is needed, meaning the areas of need, the specialty that needs the support, is known within the HSA, within the physicians on the island. So the physicians on the island know where the needs are. The education department has a framework that is already established. Because they already have a framework that's already established, it is easy for it to be administered through education department. But with involvement of those stakeholders who's on the ground, who understand where the needs are, so that these stakeholders, for example, the chief medical officer, who is supposed to have a pivotal role in understanding where the needs are, the chief medical officer should be able to, along with the medical director and other stakeholders who knows what's going on, inform the education council where they should be focusing the scholarships. That being said, the education council does invite the chief medical officer and the medical officer to sit on the interviews for medical scholarships.
Okay.
So the Education Council, they will do an initial evaluation. And after they've done an initial evaluation, they invite members from the HSA who now understands where the needs are. They invite us to assist in that process.
So in the future, I'm going to send my young Caymanians to you directly first. So there shouldn't be no hitches when they get to them then. Okay, we got that part clear. Second part, whatever happened with the offer that was made about the Bahamas?
Right. So the Bahamas, that's a very, very good question. As it is now, the Bahamas, they've provided us with the opportunity for some of our SHOs to be sent there. We had a need for quite a number of persons needing SHO training, and we were having difficulty getting them into SHO positions in Jamaica. So the Bahamas, through another colleague of mine from the Medical and Dental Council, he made some contacts, and we actually had exchanges. And the Bahamas is available. The thing is now we don't have any SHOs that's not placed.
Okay.
So all of our SHOs are now placed. But the Bahamas, they've said that if we run into problems, they're there. So they're there as an option. So no longer do I have to send them to SHOs to Jamaica. I could send them to Bahamas as another option. Yeah.
Okay,
So
getting
that's
back to my last one, getting back to the scholarships. What if scholarship money for medical was set aside?
Fantastic.
Would that be better?
That's better.
Thank you very much.
That's
Mr.
better.
Chairman.
But managed through education with the
But they can
department.
manage as long as you all have the
Yes.
final say.
Right.
They can administer it, but you have the final say.
That's
Thank you
right.
very much, Mr. Chairman.
Thank you.
Any other questions? Thank you very much, Dr. Jefferson. Thanks for coming.
Thank you, Mr. Chairman.
Enjoy the afternoon.
Thank you.
Mr. Chair, I'd just like to inform the committee that the next witness is actually my brother, so I will avoid commenting as much as possible.
Yes, Mr. Chairman, good afternoon.
Thanks for coming. As you've been informed, we're looking at the 2016 accounts for the HSA, and we need to talk a little bit to some questions for the board. So when you answer the first question, as usual, just state your name and one of the first things that comes to mind is and we are aware that the Auditor General, in addition to auditing the accounts, sent some notes to those charged with governance. Have you seen those notes?
Mr. Chairman, good afternoon. Jonathan Tibbetts, Chairman of the HSA Board of Directors. I have seen the notes regarding governance, yes, sir.
Okay. We have some concerns, but you set up a audit. Well, before your time, an auditor was hired in, I think it was 2011, and basically hasn't done any reports to the board. Can you tell us what your board is doing about getting the internal audit up and running? And
Mr. Chairman, if you're referring to the internal auditor,
yes,
yeah, the board hired an internal auditor, I think in 2011, correct. And we've come to realize through communication with the internal audit office that the internal auditor was playing more of a role of a compliance officer as opposed to an internal auditor. And as such, we have we're in the process of shifting her to the internal audit office to basically fulfill the role of an auditor, and we're hiring compliance officers to work with us in that capacity.
and I see in the response that the board has established an internal audit subcommittee in June this year. That's up and functioning.
That's correct, sir. Mr. Chairman, we would be having one of the first meetings actually coming up at the end of October with the new finance director who is coming on board tomorrow with the board of directors.
Okay. Second thing that was raised was the fraud assessment. And I guess the troubling thing about this is you're not looking to solve that matter until fiscal year 2018. And we wonder why.
Mr. Chairman, the fraud or anti-fraud policy has come to the audit committee in the past, and our finance committee, sorry, in the past, and there were some workings that we were going back and forth with the internal auditor, and it will be brought to the board hopefully by the end of this year so that we can put it in place for 2018.
And you've implemented the necessary procurement procedures to correct the inadequacies and the risk in not following the proper procurement procedures. You say you've done that in May 2017.
Mr. Chairman, that is correct.
Okay. What impact has the public authorities bill had on your board?
Mr. Chairman, we reviewed the public authorities bill, and it hasn't had a major impact on us other than the I think the declaration of interest and so forth, which has played a part, but there hasn't been a major impact on the board itself. I think it's actually done some effect to some of the employees of the HSA more so than the board members themselves.
Well, how does the board get or request regular submissions from the administration of the HSA in changes that need to be made in personnel and policies and procedures? And how do you handle policies and procedures from the board to the chief executive officer?
Okay, so Mr. Chairman, the CEO would provide to the board of directors a monthly board report, which we review and question, of course, similar to a public accounts committee hearing, very similarly with the CEO. Any questions, of course, would be brought up at that time. Any directives then that the board feels necessary to implement would be brought forth at a board meeting.
And those directives are issued in writing?
Yes, sir, that's correct. They're signed by myself monthly, and they're also tracked by the board secretary who keeps track of everything and when they were the deadlines for them and when they were accomplished and completed. It's something we put in place actually in the last 2 years that not only do we issue directives, but we issue timelines for the directives and then sign off on completion of each directive.
For several years now, there's been the average wait time for a dental appointment has been 5 or 6 months. Have you had any submissions from the HSA chief officer in terms of employing 1 or 2 more dentists reduce that down so that and it's obviously you should be able to generate income from it if you're 6 months booked up ahead of time.
Mr. Chairman, hiring of staff doesn't come to the board at all. It would only be unless the head count number would need to be increased. As I think was mentioned earlier, any position that generates revenue is looked at through the finance subcommittee and the HR subcommittees, and they can be approved at that point. Wait times, I'm sure, can vary depending on the situations, but I do know that there have been numerous requests for different positions. I can't say specifically what positions because, again, it doesn't come to the board for what positions, just whether they're revenue generating or not.
Sorry, Mr. Chairman. Thank you very much, Mr. Tibbetts. One of the things I wanted to clarify or to get from your testimony today is section 15 of the Health Services Law, where the side subheading is power to employ staff, etc. And reading from section 3, it says the board shall also determine the professional qualifications and requirements of the employees of the authority and person on the contract for services with the authority. B, the terms and conditions of employment and contracts for services. And C, the medical staff structure relating to registered doctors, dentists, and so forth and so on. One of the things, and I'm saying this as a former director of the board, that one of the things that we were, I guess, a little bit taken back on when we had just started out as an authority is that the board actually used to literally have to approve each contract, and that's one of the things that we had saw as onerous per the law, but seeing some of the stuff that has happened since, that's one of the things I'm kind of happy that is actually within the law. So I'm curious now where the law is clear that the board has this responsibility under the law. I am wondering why is it that you guys as a board is not seeing these contracts to these new employees? Because I can tell you there are some hirings that has happened recently that are quite questionable, at least to me as a committee member. And I would have feel a little bit much better if the board was actually involved or a little bit more involved as per the law.
Through you, Mr. Chairman, the board delegates the authority for hiring and firing through the CEO and her senior management team. As you can appreciate, every single contract to be signed or seen by the board would require a lot of work that we may not be perhaps qualified to even do, in the sense of doctors. We don't have any doctors sitting on the board at this time and so forth. So the delegation for the HR process has been delegated to the CEO and through her senior management team.
Thank you, Mr. Chairman. Through you. Why not a subcommittee of the board or something that would make up that? That would have been a little bit more efficient and at least ensure that we have the governance and oversight.
Through you, Mr. Chairman, we do have an HR subcommittee, and that does the oversight as far as the number of employees, the status of them, whether they're Cayman, the qualifications necessary. In some cases, the HR subcommittee would do the requirements for different positions, especially if it's the senior management level. And then they're also responsible for review of the entire organization when it comes to HR matters. So there is an HR subcommittee of the board, which has some oversight, but more on the policies as opposed to the actual operational items and hiring and resigning or retiring of employees.
The makeup of the finance, Mr. Chairman, sorry. The makeup of the finance subcommittee of the board, which members form that subcommittee?
Through you, Mr. Chairman, we have the finance director. The board chairman can sit on any of the subcommittees as except for the fraud and risk committee. Then there's the legal representative sits on the finance subcommittee as well, and the IT representative sits on there, or director, sorry.
Thank you. One of the things, through Mr. Chairman, one of the things that really jumped out at me is when I look at the Auditor General report and when I look at the summary of adjusted differences and the amounts, the quantities, and everything else of that report, it actually scares me. And I'll tell you pretty much as a CPA that if I had found myself in that position, I would resign. And I mean, these are quite material adjustments that had to be made. And one of the things I guess for this committee need to be satisfied with is the level of governance that is basically happening at the HSA. And when you look at even some of the financial performances and some of the audits, the reality of it is, from the board standpoint, which is ultimately charged under the HSA law to ensure this, I mean, the reality of it is that we need some level of comfort that the management is basically being held to task, and there's not like some kind of fun club down there, because the financial results and the financial performance does not bode well in terms of reflecting well on the board in terms of keeping management to account.
Through you, Mr. Chairman, when I joined the board of directors, I absolutely agree with the statement you just made, that it did seem like a bit of a fun club. Not that things, people were, not that employees were taking it as a joke or whatever. However, from a board standpoint, I felt as though who was giving the authority to give away drugs, for example, where we were losing somewhere in the excess of $5 million a year through the pharmacy. Who gave the authority to do those sort of things? So I came in late 2014 and began the process of cleaning up the procedures to the way we were doing things, including the payment policy, which was met with a lot of resistance because obviously people maybe turned away. And we had to work around that. We had to include the needs assessment unit in there, as well as meetings with Synico, various ministers, and we had a combined effort through different ministries in order to get people the assistance they needed and still be able to collect from the Health Services Authority position. We had to change the mindset of the employees and let them realize we're not a lending institution. We're not in the business to give away services. And it took a while, but we're seeing a significant change in the 2017 financials, and we're able to see where our payment policy is now being spread throughout the entire organization. It's working. Our bad debt provision is less than half of what has been in the past, and we're seeing material changes in being able to collect on the funds that we are billing for.
Let me, through you, Mr. Chairman, just to kind of give you my mindset of what it is that really scares me from a governance standpoint. One issue that still remains a sore point for me is that care pay contract. 12 individuals within the service, from what I understand, signed off on that contract. And the scariest part about it is, here is the agency whose primary source of revenue is cynical, the government. Any way you want to slice it and dice it, two government entities doing business with each other still nets to zero. If it's a revenue for one, it's an expense to another. Someone agreed to a contract to stick a third-party vendor inside there to take anywhere from $2 to $4 million of the people's money, something that was previous zero. The fact that someone is in prison for it goes to show the level of fraud when you consider that the amount of fraud cases against the government that have been successful has been very limited. This is one that the government was actually able to successfully prosecute. And what scares me is the very people who should have been in a position to make sure that kind of fraud wasn't perpetrated on the Caymanian people is still sitting in key management positions. And then when you do read the auditor report, you realize that not only is this a breakdown of internal controls, a weakness in governance, but it's also downright incompetent on many people that are sitting there. And the thing what I'm looking from you, Mr. Tibbetts, is somebody needs to get fired somewhere. I mean, we can't allow this culture to continue where the auditor and everyone is coming through, seeing this poor performance out of the HSA, and people still getting paid. Somebody needs to hit the road. And what it is that we would like very much from your board eventually is to start seeing more people hit the road. Now, the law gives the board the power to approve every single contract. And a lot of this stuff that has been delegated is being delegated to weaker people. We have an employee right now, there's a department with over 40 staff. And rather than you had a sudden resignation, and rather than to find someone who can act as the interim manager, they go out and they bring in someone that they said we on they they send it out to the agencies, and only one resume was sent back. I can tell you that is some kind of friend type business that is going on within the organization, and it is that kind of behavior that erodes the public confidence within the HSA. So what we're looking for now is firm leadership at a board level that can keep the management accountable, and if need be, some people getting fired. And so this is really, now I know a lot of this came from after you.
Before.
Yes, sir, before you, and you're in a untenable position. But the reality of it is that the public needs some level of confidence that the HSA is in fact being managed properly. Even if it makes a loss, I can live with that. But at a minimum, the controls need to be there. And right now, there is a free-for-all, and I'm begging you, sir, as per the law, if you have delegated that responsibility, take it back from management. Because management is actually, in my opinion, abusing that delegation of authority that you have been given to them. Start looking at these contracts, start looking at these overtime, start looking at some of these people, how they get there, start asking which church they're members of, who their friends. It's a small island. You know what I mean? And take this back to the board and deal with it. Because what frightens me is when someone tells me that you have 833 staff and the budget is 890. So you're 6% down on your staff complement, but you're over in your staff budget. When it tells me that you're growing revenues, but you're not collecting it, and you can't do a basic understanding of what accounts receivable is. Not allowance, not bad debt, basic. This is not something that we just find out today. The Honorable Financial Secretary highlighted this last year when it came out in terms of explaining the definition. And a year later, the definition still isn't clear. So this is the kind of stuff that scares us. And when I consider that the HSA is $100 million a year organization, we need people who are switched on managing this entity, and we're not seeing that. So I'm begging you, Mr. Chairman, for your directors, please take a more. If you have to micromanage via subcommittees, please do. But these level of audit adjustments, I can tell you, if I was chair of the finance subcommittee, the only testimony I would have been given today is this is who got fired for this. Thank you, Mr. Chairman.
And following along with that, how is it possible for your administrators to exceed your overtime budget by 300%?
Mr. Chair.
Or did the board authorize that?
Mr. Chairman, I think that question was actually asked earlier to the CEO. The board would not authorize overtime as such. We don't have any authority.
What are the consequences of a chief officer exceeding budget allocation in relation to something like overtime by 300%? Are there any consequences?
Mr. Chairman, that would go through the HR subcommittee, in which case the director responsible for the HR subcommittee would be made aware of it. There would be obviously reallocations to be able to cover the overtime budget. However, it would then be put in for the new budget to hire the additional staff going forward.
But the curious thing here is that management response to this 300% exceeding your overtime allowance is to do a business case to outsource this stuff. I mean, that is not addressing, and we know that you have 57 people approved in the budget that they haven't employed. Now, whether these are the same people that are, because you haven't hired those people, you're overworking your existing staff.
Correct.
Yes,
sir. Yeah, I think that is, Mr. Chairman, I think that is the point, is that some staff are filling dual roles right now, and we're working to streamline to make sure that each person is responsible for their job and not trying to halfway fill another job. So that's something that the board has taken under it through the HR subcommittee to identify the best possible scenario for staff. We don't want to overstaff the organization, but at the same time, obviously we are in need of certain staff in certain areas to cut down on overtime and to minimize it.
Because, I mean, if you outsource this stuff, then you're going to be paying whoever you outsource this the profit, and it's very unlikely that they can do the service for any less than you can do it.
Yes, sir.
And but it says it's going to be in the fiscal period 2018, so maybe you can put a stop to that before it gets started.
That's the intention.
The other concern in the governance structure is the submission of the register of interest, and the implementation date is ASAP. This was some months ago. Do you know whether the register of interest had been completed?
Mr. Chairman, are you referring to the board of directors? Or are you referring to management or staff?
Both.
I know that for the board of directors, Mr. Chairman, we received that notice and it was completed. And I do know that the staff, not only the board felt that in a better governance pattern, that we should go ahead and get register of interest for the physicians as well, because there was some murmuring in the community that some of the physicians were referring patients to friends or perhaps other interests that they may have. And so we've done that for the physicians as well.
And what is the board doing about the breaches of the HSA law in terms of the 90-day cash reserve?
Mr. Chairman, that's something that we're working on as far as being able to be within the law. Obviously, one of the best ways to do that is to actually do the job of the HSA, and that is to collect the funds for the services provided and be able to maintain the 90 days shortfall.
But are you on any kind, does that implementation require any incremental increases in your reserve, or are you just waiting until you can do it all one time?
Mr. Chairman, I think it is an incremental increase. Obviously, we can't hit it all one time with the shortfall, but I know that is something that the finance committee is working towards, getting us back on par with the law in regards to the reserves.
Through you, Mr. Chairman. Since you just raised up the finance subcommittee, Mr. Tibbetts, I just want to highlight, when I look at the summary of audit adjustments, I mean, that came out of this audit. Adjustments for 6.4 million, 1.4 million, 251,000, 506,000, 1.752 million, 789,000, 600,000, 17.4 million, 9.5 million, 26.9 million, 8 million, 55 million. I mean, and the one that scares me the most, surprisingly, is one of the smallest ones for bank charges. Because what it basically tells me is that the bank accounts weren't reconciled. And this is like one of the basic functions. And talking about cash, which in itself is a high risk area. I mean, this kind of, I mean, I gotta be honest, I'm 44 and I've been doing accounts from I was 16, and I've never ever in my life seen something like this, and I've seen some stuff. I have done cash tracing for BCCI, trying to find an $18 billion black hole, and I'm going to tell you, this is right up there in terms of adjustments. I've never ever seen anything like this. And I'm begging you, please, to get your finance up. I think your new finance director is
Will be through you, Mr. Chairman, new finance director. I'm actually meeting with her this evening.
Yeah, I think
after this
Miss Solomon, please. I think that's the word thing I was
no,
told.
Miss, it's not Miss
Or Cove or something.
Cover,
Yeah,
correct.
well, yeah,
Yes,
she
sir.
was previously Solomon. My bad.
Sorry.
Ask her, please, to really take a look at these adjustments, because I can tell you right now, seeing this, it has completely eroded my confidence within the finance function. Because these are serious material numbers. I mean, how can you be missing numbers for 50 odd million, 17 million, and all that kind of stuff when you consider that your fixed asset is only 72 million? I mean, literally, the auditor came in and did your job. You know what I mean? So now you went out and you hire a consulting firm to basically come in and look at your internal processes again. Previously, they hired another consulting firm to set up the department. I have to ask myself, is the finance function equipped to deal with $100 odd million institution? And like I said, this report does not reflect that. And that is pretty much what it is that we want from the board: a more active role, a much more governance.
Through you, Mr. Chairman, the board hired a firm to come in and assess the audit points and how to get us a clean opinion in the upcoming year, and that's obviously one of the items that have to be addressed would be any kind of adjustments and so forth, and the point of the firm coming in would not be to continue to hire some outside firm, but as I mentioned, to clean up the audit points and maybe put the controls in place. We're about 85% compliant at this point. However, that 15% is where is causing all the issues. So the firm will come in and give us the controls and the plan to be able to get the clean audit opinion. And so going forward, with that, we would reduce the adjustments and hopefully be able to have a straight line financial statement for the end of 2018 is the goal.
Just a heads up, to you, Mr. Chairman, is that the EPS for government isn't signed off because of the post retirement healthcare liability issue, which is standard in that one. So I would just caution you to caveat it that if there is a qualified opinion next year, it will be based on that as opposed, because understand it's a difference of opinion between the government and the Auditor General's office, which we can probably live with. But I'll just caution you to caveat it along those lines to say, if anything, it should just be that one left as opposed to.
Through you, Mr. Chairman, member, you're absolutely correct. However, I have written to the minister requesting a government standpoint on the pensions benefit. So from the board standpoint, we're trying to get a clear understanding as to how we can go forward with that without it being a point, and we can get the clean opinion as well. So
I just want to caution you, when you overpromise that you're going to have a clean one, and then next year we come back and we see this thing sitting there.
Through you, Mr.
I'm not sure that your understanding of what the consultants is being brought in is the same as we've been given evidence this morning. In terms of what you're talking about, I think it's Deloitte you're hiring.
Yes, sir.
But it was an evidence we got this morning that they were going to be more involved in trying to tighten up the policies and procedures as opposed to working on getting you to a clean audit.
Well, I think that'll be part of it too, because the internal controls are weak, and I think that's one of the reasons.
Agreed, but what he's telling us now is that basically they're being hired to move the audit to a clean audit in all areas.
Mr. Chairman, that's
And
correct.
if I know them consultant firms, that could be another consultant fee.
Mr. Chairman, the board hired the firm Deloitte to get a clean audit opinion, to put in place policies and procedures for us to get the clean audit opinion. They're not coming in to do the work as such, but to put policies and procedures in place. And I have told, as Member Saunders has stated, I have told the senior management that if we do not have a clean opinion by the end of 2018, at that point heads will roll.
You're generous.
If I recall, they also put some concerns about your inventory management and you're not having perpetual balances and stuff. Is that also going to be a part of the consultant work?
Mr. Chairman, that would be part of the procedures that they evaluate.
The SPS that was just delivered, the government made a big deal out of that. You've gone to reverse auction for purchasing. And I think it claims 37% reduction in cost. What controls have you put in place with reverse auctioning, particularly as it relates to pharmaceuticals and other time-barred stuff to ensure that reverse auction is in fact a good thing to do?
Mr. Chairman, what we'll have to do is look at the procedures of the past and how well they worked. Obviously, with pharmaceuticals in particular, they are time sensitive, and as you're well aware, it's not something that you can just jump and grab any time if they're going to expire shortly and so forth. So we'll have to. It will take some time to be able to evaluate the reverse auction versus the prior procedures.
One of the under reverse auction, if the original bid is for a particular medication made by a particular company, does the person who's underbidding in the reverse auction have to bid the same medication by the same company?
Mr. Chairman, that would be up to the medical director to decide. I wouldn't be able to confirm whether, he would accept a different medication from a different company. I can't speak to that.
Because I think it's something you need to pay attention to. Because if the original bidder was established manufacturers with proper track record, and you're getting, and it's gone through all the processes for approval and everything else, so you're getting bioavailability, you're getting dissolution rates, etc., all the binary stuff is brought up. If that person is competing against some generic thing that is made in some third world country, obviously they'll get the cheaper price. But what mechanisms, if any, have we put in place to ensure that if we're buying that kind of stuff, that we know we're getting what we're paying for, and it does in fact have in it the active ingredient that we're trying to buy?
Mr. Chairman, I agree with your point that indeed, if we're looking for a particular drug from a particular manufacturer, obviously we would have to get the exact same bid on it. Otherwise, it would be of no use. I know that there are generic drugs that are used. However, when a bid goes out for procurement of a certain drug, that particular drug has to be purchased.
Any other questions?
Mr. Chairman, through you, if I said to you, Mr. Chair, that a unit needs to be deep cleaned and the ventilation is clean, you don't understand where I'm coming from.
Through you, Mr. Chairman. Yes, sir, I do.
Beautiful. Could I ask you to get us a schedule and show documentation how often the units and the schedule as well, documentation and the schedule, how it is scheduled, and could I ask you to get that for us, please, as quickly as possible?
Mr. Chairman, through you, member, are you referring to ventilation system or
in the units where the patients are?
Oh, okay.
Because I've been in
the
some of
rooms.
those units for 5, 6, 7, 8, 9, 10 days continuously every day with different people. Turn around and next morning they move out, evening somebody else is in. I just want to know how often and the schedule those units are deep cleaned and the ventilation in those rooms as well.
Through you, Mr. Chairman, I will provide that schedule from the CEO's office.
Thank you very much, sir.
Well, if you could include in that the methodology for cleaning a room that is unoccupied, for cleaning a room that is occupied, and for cleaning a room when an occupant leaves. But it should be three separate.
Through you, Mr. Chairman, the report will include the different techniques used for each of those particular requests.
Okay. Any other questions?
I just want to wish you luck. Anything we can do to help. But I just need to say this, Jonathan. I mean, I have confidence in you and some of the members that are there that I do know. But I'm just going to say to you, take control of that organization. It's a $100 million organization, and based on some of the testimonies I've heard from the seniors, well, 3 of the senior staff that came this morning, it is not reflective of an organization of that size with that level of responsibility. If they need to train them, train them. Try to manage them up, and if not, manage them out. It's as simple as that, but this is something we need to get right. This is not on-the-job training for the kind of business that the HSA, what we expect from the HSA.
Through you, Mr. Chairman, member, thank you, and I certainly will take your advice. If I could just share briefly, coming on to the organization, it has been a challenge, to say the least, from my own background in working with a power company to working with a health organization, to change the mindset of some of the people. For years, I was told that there is this unwritten law that you have to take care of anybody and everybody, and I said, that's absolutely right, we do, but we have to get the funds for it. And it I must say the senior management, in most cases, has made an about face as far as the idea of just providing service as opposed to collecting a fee for it. So we are seeing that, and we are pushing for it. in every aspect of the organization. It has not been something that happened overnight. It has been years, and in fact, about 2 years now, that it has taken for us to get to this idea that every single service must have a fee attached to it, and every fee must be collected, whether it is through a program through the government, whether it's through an insurance issue, whether it's through a self-pay. It has to be collected. And the senior management has come on board with that. I trust that our new finance director will continue to push and support that. And I do take to heart your genuine advice, member, and you can be assured that next year you will see a different report. And I'm looking at numbers perhaps that you may not have from 2017, and it's already encouraging to see that the efforts are rolling in the right direction. And I appreciate the support of this committee.
So thanks, thanks very much, Mr. Chairman, Board Chairman. What I would say to you, if you take a look at your revenues in terms of what is government versus non-government, and look at what is costing you to collect the non-government and your bad debt, you may as well just say, you know what, it's just probably cheaper to not collect it and just have nobody collecting it. The HSA may be better off. But if you are spending more money trying to collect something than you're collecting, then clearly there are serious inefficiencies there. So just a little bit of analysis you may probably want to consider.
One last question. Is the HSA charging the fees that are prescribed by the Health Insurance Commission?
Mr. Chairman, those are the fees that only the fees that we can charge. Unfortunately, we don't have the freedom to
You're
adjust.
charging the full amount of the fee.
Correct, sir. Through Charge Master, there was a delay in the charges to government as far as other private insurance firms were receiving charges, and there was an agreement with government that there would be a 3-year hiatus on charging the full fees. However, that is now happening as well. So that's another thing where we saw that there was a shortfall. We fixed that.
Thank you very much, sir.
Thank you all. How are you, Mr. Come to the break. We can get you in quicker. I said, come to the break. We can get you in quicker.
swear by Almighty God that the evidence I swear by Almighty God that the evidence I shall give to this honorable legislative assembly shall be the truth, the whole truth, and nothing but the truth.
I swear by Almighty God that the evidence I shall give to this honorable legislative assembly shall be the truth, the whole truth, and nothing but the truth.
Good afternoon, Ms. Ahorn, and thanks for coming, and also to Ms. Butch as well. As usual, when you answer the first question, just state your name for the purposes of the record. As you would have been informed, we're dealing with the Health Services Authority financials for 2016, and what we want to talk to you all at the ministerial level is we have some concerns about the financials, and we wonder whether they have been reviewed by the ministry and what is the minister's position on the 2016 financials. So maybe we'll start there. You've seen it. What is your response to the financials?
Thank you, Mr. Chair. My name is Jennifer Ahern. I am the Chief Officer and Permanent Secretary in the Ministry of Health, Environment, Culture, and Housing. And if I may, Mr. Chair, before I respond to the question, if I could just give an update on Miss Brenda Riley from this morning.
We would appreciate that very much, yes.
I've been advised that she is stable. They're still running a few tests to try and determine what the situation is, but that she is stable for now.
Thank you very much. That's very much appreciated, and we wish her well, and we'll keep her in our prayers.
Okay, thank you, sir. The ministry did receive the financials. Our responsibility is to review them and submit them to Cabinet for their approval, to submit them to the Legislative Assembly for tabling. These, I believe they were tabled on the 24th of August, so they have been tabled in the Legislative Assembly. When the financials came to the ministry, we reviewed them. We noted the qualifications that were outlined in them, and we asked the Health Services Authority to provide us with their comments on those qualifications and their plans to try and address them and resolve them. I'm sure that you've heard through the course of the day about some of the steps that the HSA has been taking to that end, with their goal of a clean audit opinion. I believe it's in the 2018 audit is their goal.
The big one that we've been talking about all day is the alarming increase in public debt. Sorry, not public debt. Mr. Jefferson, my apologies. In the bad debt provision for the HSA, in that we've almost doubled in 2 years what it took to accumulate in 12 previous years. And we wonder what the explanation that was given to the ministry, or whether the ministry queried that or not.
Thank you, Mr. Chair. It was a question and continues to be a question that the ministry asked the HSA in terms of how they plan to address the issue of what appear to be unrecoverable debts and their treatment of them. Obviously, accumulating it year on year without addressing it isn't really a satisfactory position for them to take. And I believe that they have now moved forward with looking at actually writing off some of the very old historic debt and looking at how they're going to prevent it from accumulating at such a rapid rate as we move forward through time. I think one of the benefits that we're seeing now that we're catching up with these financial audits is that some of the issues that are being flagged, they're now able to address them and hopefully resolve them with successive audits going forward.
Just to back up a little bit, is there any particular reason why? Because normally I think the PMFL law, if I recall correctly, requires a report to be tabled along with the financials. Is there any particular reason why, or did the HSA not present to you a annual report with the financials for cabinet consideration?
Thank you, Mr. Chair. We have received, in the past, we have received annual reports, but I believe, and perhaps the FS can advise, the requirement for the annual reports, I thought, had been deferred under the PMFL for a period, or no, that's not the situation. Okay. So I don't recall if we have an annual report to go with this 2016 financials. We received these in, I think it was April of this year, so I haven't seen an annual report to go with it.
Because we would expect that a lot of the things that we're having to generate questions about now would be explained or dealt with in some manner in the annual report. And as I understand the PMFL law, what the PMFL law talks about is an annual report of which the audited financial statements is a part. It seems that most entities are now resorting to simply tabling the audited financial statement, which is not, I don't believe, what the PMFL law requires. But I don't know if Mr. Jefferson has anything to add to that or not.
Thank you, Thank you, Mr. Chairman. Mr. Chairman, just to clarify very quickly, in terms of deferral, as Ms. Ahern just spoke about, that was the situation with respect to the reporting of outputs back to the Legislative Assembly. That aspect has been deferred. Most recently, in fact, a lot of agencies, meaning ministries and portfolios of central government and statutory authorities, have actually done a much better job in recent years by actually producing annual reports, which you've just said correctly, does include the raw financial statements themselves. In addition to then sitting on top of that would be comments about how the information on the particular organization, how many staff it had, the makeup of staff, key events that have taken place during the course of the year, key performance indicators, plans for the future, etc. So we've actually improved. At the very beginning, it would be correct to say that the agencies throughout the public sector, their primary concern, largely because we were some years behind, was to submit the audited financial statements as quickly as they were available as representing an annual report, but that's not correct. The financial statements are not an annual report, but we've done a lot better in recent years, and it's something that we certainly want to continue to do going forward, and not to just revert to tabling of the financial statements themselves without management information on top of that.
So next year we would expect to get a proper annual report of which the financials are a part of, because it makes our job easier and gives the public a rounded position.
Yes, we will certainly. The ministry has a draft annual report for the 15-16 financial year. However, our ministry audit is still ongoing, and the HSA contributed to that annual report, so they may have the document. I will see if I can get it through Cabinet and have it brought to the Legislative Assembly.
Part of the explanation given to us on the rising in the bad debt is that there doesn't appear to be proper policies and procedures from the ministry level down to the board, and that there's an expectation that there will be an annual adjustment to the bad debt rather than allowing it to accumulate. Does the ministry have any plans, or has any such policies been issued to the HSA to say that if you have a bad debt provision, that for the year, that amount at least is written off while you deal with the rest, you just simply add it to the pile?
Thank you, Mr. Chair. The ministry hasn't issued a policy to that effect. My understanding is that the authority for that rests with the board, but certainly given that they are taking steps, I think that they are taking it in hand and looking at addressing it.
The board seems to believe that they only have the authority to recommend to the ministry to ask cabinet to forgive the bad debt. And I think that somewhere along the line we need to get that clarified, because I think that is part of what's leading to the just adding it to the pile as opposed to trying to adjust it annually.
Sorry, Mr. Chair, I've just had a sidebar with my CFO. That's something we'll look into clarifying.
Yeah, because the other thing that we have a little bit of concern is that the classification at the HSA for bad debt seems to be only time as opposed to other considerations. And I think there needs to be probably a policy directive or something from the ministry down to them to get this thing cleared up once and for all, and then make sure that it is adjusted annually. On we provide some of the money in your ministry for a number of votes, which totals somewhere in the region of $19 million. What is your requirement in terms of documentation from the HSA to access those votes?
Okay. Mr. Chair, thank you. The funding that the HSA receives from our ministry is in two different pockets. One is for services. That, for example, is HEA2, which is the healthcare provided to the indigent. Some of the other outputs are operating subsidies to make sure that the HSA maintains a particular level of services that they can't recoup either through fee-for-service charges for the services provided. The Health Services Authority submits invoices to the ministry for us to review, along with some supporting documentation. I'm actually going to ask my CFO to give you more of the technical details behind some of the control processes that the finance team at the ministry has in place in dealing with those requests for funding.
Mr. Chairman, Nellie Pucci, Chief Financial Officer at the Ministry of Health, Environment, Culture and Housing. Apologies for my voice. I seem to have gotten a sore throat, so it sounds a bit scratchy. In terms of our billings received from the HSA on a monthly basis, we would receive requests, invoices. Sometimes those are in advance, as the HSA would need to receive payments prior to some of the actual numbers being realized, so that they would have adequate funding for cash flow purposes. However, on a quarterly basis, those invoices are trued up against actual spend to ensure that we are paying against actual numbers. We would receive usually an emailed invoice, and we will get some supporting information as to what is behind the numbers and the outputs that are received. In terms of an estimated number, usually it's in the region of about $2 million that we fund on a monthly basis to the HSA, and that's across the majority of their outputs.
Mr. Austin.
Thank you, Mr. Chairman. Just a question going back to the origins of the bad debt, which, again, as the chairman alluded to, has dominated our conversation much of the afternoon. 2011, the care pay system was introduced with the goal of preventing the ongoing accumulation of bad debt. But as we all know, it worked the exact opposite. It actually cost us more money to implement that system. And there is a growing perception that the accumulation of bad debt has a lot, if not everything, to do with the billing process itself at the HSA. looking forward as a means of avoiding the mistakes of the past, can the ministry state what alternative to care pay will be instituted to address the issue of the billing process at the HSA?
Mr. Chair, through you. The Health Services Authority's operational processes and decisions are something that I know that they're looking at on a continuous basis and looking at tightening up their claim submission turnaround times, how clean the claims are when they go in, looking at reducing the rejections of the claims and so on. I can't speak to that in detail because I'm not familiar with their operational systems there. From a national or ministry perspective, one of the things that is driving, there appears to be driving the bad debt allowance that the HSA is carrying is the category that's termed self-pay patients. So these are patients who come in and either have no health insurance or don't have the ability to pay their copay or deductibles on their health insurance plan. Some of those we pick up at the ministry level through some of the outputs that we have. We have an un- and underinsured children. We have chronically ill patients over 60. But there are going to be others who just fall into that pure self-pay bucket. We're going to look at increasing our enforcement capacity at the Department of Health Regulatory Services that has oversight for the Health Insurance Commission. One of the things that we've been struggling with, for one example, is uninsured children. So under the health insurance law, all children, all residents of all ages are required to have at least a standard health insurance contract in place. There was a misconception for a number of years that children's health care was free and that they didn't need to have health insurance. And so what was happening a lot of times at the Health Services Authority is parents were showing up with their children, and even if they had insurance, they weren't necessarily pulling out the card. We introduced a form that the registration clerks have the parent fill out to say, I acknowledge that I should have health insurance for my child, and it gets sent into the Health Insurance Commission. When we introduced that, we found that some parents were then able to pull out their insurance cards and we were able to process it. But one of the challenges that the Health Insurance Commission has had is the capacity to follow up on all of those forms. So it's been a continuous battle for them along with all of the other things that they need to do. One of the things that we're hoping to be able to do in the upcoming budget is to add another health insurance inspector to the cadre at DHRS. And we're also looking to recruit for a deputy director of health insurance to further bolster that capacity.
If I may ask, in the broader strategic context, I directed this question earlier to the CEO and was told that it was a better question to address to the ministry and the chief officer, so I present it again. The Auditor General's report identified that, and I quote, Cayman's health care system needs a major overhaul if government is to properly meet the health care needs of the local population. The HSA or ministry's response to this strategic context was the development in 2012 of the National Health Policy and Strategic Plan for the Cayman Islands 2012 to 2017. But unfortunately, it has not been fully executed. The Auditor General further went on to state that implementing the NHPP will result in some improvement of the health system, but some goals are too ambitious. The good intentions are there, but there is not the means to fulfill them. I wonder if you can state to this committee what aspects of the NHPP have been implemented versus what aspects still lack the necessary means to achieve them, and are these necessary means, quote unquote, connected with a lack of human capital, which again is something that we also heard today, that there's budgeted for 890 positions, but we have staffed 833. So not only do we need 57 more positions, but potentially another 40 on top of those 57. So the question is, of the aspects of the NHPP that have not been implemented, is it because of a lack of human capital?
Mr. Chair, through you, I don't have my NHPP document with me. And and I don't have an update that I can provide on that basis at this point. I would say, and just to clarify, the numbers of staff that you're referring to, that's at the Health Services Authority.
That is correct.
Okay, yeah. But I would say that certainly the review of the National Health Policy, is something that we are planning to work with PAHO on Pan American Health Organization on early next year, 2018, with a view of identifying, what are the strategic priorities, revisiting what we have there as a framework to see what still is applicable today and what are some of the adjustments that we need to make. I think the observation that it was an ambitious plan is a valid one. And I think that over the time frame of the policy, while there hasn't been a formalized work plan done for each of the objectives, I think that the work that the ministry has done and the work that the HSA has done, the work that the Department of Health Regulatory Services has done, has fed back into looking at achieving the overall vision of the policy, which is health and well-being for all.
When you state that that plan is still being developed with PAHO or otherwise, can the ministry state whether an operational plan for that national health policy, which will deal with things like implementation, monitoring, and evaluation to track the progress, what is working, what is not working, has that operational plan that would be somewhat of the companion document to the overall strategic health policy, has that been developed yet?
Through you, Mr. Chair. No, that document has not been finalized. We had started working on that with the technical assistance of Pan American Health Organization, but we didn't complete it. We do plan to make sure that because we found that in the absence of that kind of a document, it is very difficult to track your progress. And it's very important to identify what those key performance indicators are going to be so that you can determine if you are making progress along the road that you want to be moving down. So certainly one of the things that we have discussed with PAHO in talking about the process in the new year is to make sure that right on the heels of doing that policy that the operational plan is done so that we will have that roadmap.
Thank you, Mr. Chairman. Through you, sir. Madam Chief Officer, thanks very much for coming. What I'm trying to understand, and my question takes a different track than the others. I'm trying to understand from a governance standpoint the role the ministry plays with regards to the HSA, and then two, from a strategic standpoint, the role that the ministry plays in this regard. Because the reason I'm asking this is that we were trying to kind of determine the strategic direction of where we see the HSA going from some of the non-medical staff or personnel that testified this morning, and the answers weren't forthcoming, more as to defer policy to the ministry. So I was just trying to get a better understanding of the ministry's role in that regard.
Through you, Mr. Chair. The Health Services Authority is a statutory authority that is set up as an arm's length body. The ministry, under the Health Services Authority law, the minister is only able to issue directives to the HSA proactively, not in response to an emerging issue. The ability of the ministry to influence and direct the HSA is evolving with some changes with the Public Authorities Law that's coming online or has come online. Generally, the ministry's direction to the HSA has been that their role is as the public hospital to make sure that they are the primary healthcare providers for the government, for the public, and that they make sure to deliver those in a high quality, accessible, cost-effective manner. That has been something that the HSA has been working on through the years, and something that I think that they are taking steps to make sure that they're delivering on.
Thank you very much. What I wanted to gather from your answer, and this is what I'm about to read, is coming from the Auditor General's report, entitled Ensuring Quality Health Care and a Healthy Population. And on page 1, it says, the Ministry of Health, the ministry, is responsible for the regulation and oversight of all health services. Its main objective is to ensure a healthy population and a quality health care to the people of the Cayman Islands. Accordingly, the objective of this audit was to determine whether the government's role and responsibilities in achieving these aims are defined and communicated clearly and managed effectively. The audit examined the manner in which the government has established and communicated its roles, responsibilities, policies, and strategies in the health system, its authority and capacity to deliver on its related accountabilities, its means of promoting and monitoring compliance with the legislative framework, the performance management and reporting framework it has implemented, and finally, the extent to which the results and outcomes of the health system are consistent with any performance expectation established by the government and with relevant international standards. If I shift over just on page 3 in terms of the conclusion, and I mean, there are other stuff there, but I just wanted to get to the conclusion in terms of the purpose of the audit and what the conclusion was. We concluded that there are shortcomings in the government's management of some of its roles and responsibilities to the extent that they may compromise the achievement of its stated aims of ensuring quality health care for the people of the Cayman Islands and a healthy population. The government does not have the resources or the information required to manage the health system effectively, and neither the Legislative Assembly nor the public can be confident that high quality health care is being delivered or that value for money is being achieved. With that said, and this is where I guess the rubber meets the road, in that, as I've said to members before, this is a $100 million organization. It is not a quote-unquote patty shop, and it has a serious responsibility. And when we look at the financial performance of the HSA, and then we recognize also that a lot of the shortcomings and the reason for the qualified opinion is because the internal processes are weak. And then when you look at the number of audit adjustments that take place, I mean, some of these, when I say are quite material, it literally blows the mind. I am wondering where along the way does the ministry put its hands up and say, guys, ultimately, this is our responsibility. We have delegated a portion of this responsibility to you, but I have a report here that basically says the Legislative Assembly nor the public can be confident what's going on over there. And the reason why I'm saying that is, listening to the CFO this morning, based on the numbers and the feedback she gave us, it's clear that there's a complete misunderstanding of the numbers. And what scares me is the fact that the ministry staff and those who are more in a governance role to some extent basically comes and repeats the same inaccurate information. And to kind of borrow from Reagan, it's okay to trust, but we need to verify. And it's when we start digging into the numbers, we realize that one, the numbers don't make sense. Two, when you do look at the level of audit adjustments, and I don't know if this is something you look at, but I'm begging you to please take a look at it. It's literally mind-boggling. And then ask yourself the question, can we seriously trust any information that we're receiving from the HSA in this regard? Because at the end of the day, I mean, you're the one that is here giving an account for their financial performance. And at the end of the day, it also leaves you in an untenable and unfair position that you're basically being asked to evaluate or comment on someone else's performance, when in fact an organization of that size with that qualifications of employees should be able to stand there on their own 2 feet and not for us to be calling to the ministry. We asked about strategic direction, that's being deferred to the ministry. That's a little bit disappointing. Luckily, Dr. Jefferson, at least in his own way, has his vision, which is something good, but that is one of the things that we would have expected to be hearing from the senior management of the HSA, and that is not happening. So the thing about it is, as we look at all of this, what we're trying to figure out now from a governance standpoint is what does the ministry expect their role, and then more importantly, how do they deal with the level of either incompetence or the issues that are within the HSA. That's what we're looking comfort from. At least that's where I'm looking comfort from. Thank you.
Mr. Chair, through you, the role of the ministry that's referred to in the Auditor General's performance audit, it speaks to the various facets that make up our healthcare system in the Cayman Islands. And, you know, we have legislative frameworks, we have a regulatory arm in the Department of Health Regulatory Services, we have service delivery in the Health Services Authority, the private sector healthcare providers. We also have the public health functions that MRCU, Mosquito Research and Control Unit, and Department of Environmental Health are performing as well. From the ministry's perspective, we have the responsibility and have worked hard to, when it is brought to our attention by the relevant departments or in the course of the directives that we receive from Cabinet, make sure that the legislation is reviewed and updated, that it's responsive, make sure that the things that need to be in place to facilitate some of the different roles and responsibilities of the departments are addressed. You mentioned the issue with, what was it? It's okay to trust, but it's better to verify. And I can assure you that our ministry's finance team does do that. When we receive the invoices from the Health Services Authority, I know that my CFO and her team do go through them. The budget that we get, the budget requests that we get and the forecasts that we get from the various departments, and particularly the Health Services Authority here today, they are based on what their projections are for the cost of services that they expect to provide. When we receive the invoices, the CFO and her team make sure that the amounts are supported. They do question the figures when we receive their budget request to make sure if, for example, there's a projected increase in a particular output, we do ask what is driving it and how it might be addressed. So I'm not sure if that answers all of the questions that you had.
I think that what seems to be the gray area is what is the role and function of the ministry and what is the role and the function of the HSA.
Okay.
As I understand it, the ministry is the body that is responsible for policies and procedures and legislation governing the public health of the country. The HSA is simply an arm that is created under statutory legislation to implement a certain aspect of that policy. What we're not hearing is any alarm bells from the ministry in that whether the HSA is meeting its responsibility in its implementation in achieving the objectives, and we're wondering who sets the policy and who sets the objectives for the HSA to routine. What kind of and how often are directives or have any directives been issued to the HSA board in terms of what is expected to do?
Okay. Thank you, Mr. Chair. And that is what you've described is the function. The HSA is a service provider. They're a service delivery agency, and they are to deliver those services in line with what the overarching policy of the ministry should be. The ministry, under the guidance of the minister and cabinet, I view our role as a facilitator to make sure that, as I was saying earlier, that the appropriate frameworks are in place, the appropriate agencies are empowered to do what they need to do to deliver. The HSA, as an organization, has they have their own organizational strategic plan that they have set, and I don't have it, and I don't know the last time that they reviewed it, but I do think it was fairly recently, and they identify some strategic directives from that plan. That plan is in keeping with and in line with some of the goals that are outlined in the National Health Policy. In addition, it has happened in previous instances where an incoming Minister of Health has met with the board and sat down and expressed their views and their vision in terms of what role they see the HSA playing in the healthcare system. The HSA is the largest provider in the system. They're the largest provider of primary care, and they are the government hospitals. So they have a fairly significant role to play.
we were it was suggested this morning by the chief officer of the HSA that one of their strategic goals is that they want greater emphasis on primary health care. What policies does the ministry have under consideration, and does the ministry agree that that needs to be one of their major concerns, the primary health care, and how does the ministry expect to achieve this emphasis on primary health care?
Thank you, Mr. Chair. I would agree that absolutely the emphasis needs to be on primary care and prevention. I think we have heard and have seen over the years that really what we need to do as a country is to, and globally, this is a global situation, everybody needs to make sure that they're taking steps for prevention and wellness, and that they're trying to preserve good health as opposed to letting it go. One of the things that the ministry did in 2013 is we reviewed the health insurance law and the standard health insurance contract that is the minimum level of benefits that everybody is legally required to have. And one of the main changes, or one of the significant changes, was to increase the outpatient benefit. Prior to the amendments to the legislation, the maximum outpatient benefit was $100 per year, which obviously, if you're at that level of coverage, you're not likely to use that to go and get a wellness checkup. You're going to save that until you feel unwell and you want to use that benefit to go to the doctor. So we amended the standard health insurance contract to increase the outpatient benefits. We also introduced a wellness benefit as part of the base plan that people can use specifically for those wellness checkups. And it was put in place in order to facilitate people taking those steps and embracing primary care and making sure that they get those checkups, that they get their medications, that they take care of themselves and hopefully don't end up being catastrophically ill. Another initiative that the HSA embarked on, I think it was in 2009 or 10, was to focus on the Department of Children and Family Services clients who went to the Health Services Authority and to align them with a primary care physician. Previously, before that, if you made an appointment, you might see the same doctor, you might not. You didn't have a doctor who was responsible for making sure that you kept up with your blood sugar checking or your hypertension, your blood pressure checking. So with the K-Health program, the Health Services Authority put that in place for the DCFS clients, and we have seen over the years that the numbers that they've been measuring from that in terms of the controlled hypertension, the controlled diabetes, the numbers have been improving. So that's something that they're looking at, and I believe the HSA are in discussion with Cineco about rolling that out to a broader population of Cineco-insured patients. Some other things that we did one of the other things we're looking at right now in regards to the health insurance law is trying to identify whether we need to have another plan, another standard plan just designed for seniors, for older persons. Obviously, there are going to be some benefits in the SHIC, the current SHIC, that probably aren't applicable for seniors. Their needs are going to be different. So one of the things that the Health Insurance Commission is looking at now is whether we need to arrive at a second standard plan that would be targeted for older persons with a different plan of benefits.
Isn't that going to fly in the face of the whole concept of health insurance, in that the younger help pay for the old? Because I can promise you, if you give the health insurance providers the opportunity to price a separate plan for seniors, that is going to be priced. And when you look at the demographics of seniors on which an actuarial would calculate a premium for that, is going to be astronomical. My limited knowledge of the industry, my recommendation is that be discontinued immediately, because that is fraught with danger and it ain't going to help the situation, I can promise you. Because the whole concept of global health insurance is that the young help pay for the old. And if you give the help, yeah, and spread the risk across the whole demographic. The next thing, if you do it for the 65s and older, then the next thing I hear is that the young people want one for the under 20s and under 30s because they shouldn't be. It has to be a global. I would be very.
True.
One of the things we're asking the actuaries to advise us on in this is that type of impact and what that impact might be. It's something that's been put forward as a result of some of the complaints that we have heard about the SHIC plan, particularly for older persons, and the shortcomings of that plan for that group. And so one of the things that we have flagged that we would want to consider and that we would want advice on from the actuaries is exactly that. If we were to move forward with that kind of a plan, what would the impacts be across the premiums across all of the cohorts?
Sorry, through you, Mr. Chairman, before I ask my next question, I just want to confirm with the audit team, if generally, and forgive me, I've been on the audit a long time, you guys normally use 5% of balance sheet as materiality, or what do you guys normally use for materiality?
Through you, Mr. Chair, it depends on the entity, but generally it would be for the expenditure. We would use 2% at the higher level if it's a very low risk client. If it's high risk, we use 0.5% of expenditures.
So, through you, Mr. Chairman, what was the roughly materiality that you guys use on the HSA audit?
Through you, Mr. Chair, we actually use 2%. However, we actually use a level of performance priority level for testing items that was more aggressive than 2%. So there was two tiers. There's a global authority level that was 2% of all expenditures. And then we actually took a portion of that then at 60%, I think it was, to test the expenditures and the assets.
Okay, thank you. Thanks very much for that. Through you, Mr. Chairman, the reason I asked that question is when I look at the total asset for the HSA for the 2016 financial year, it's 115 million in total assets. And liability plus equity would also be 150 million just to get it to balance. The total amount of audit adjustments is $105 million. That is 91% of the total. And what I'm trying to get from the ministry is at what point or what number is it going to take when your total asset is 115 million and your auditors have to recommend $105 million worth of adjustments in order to sign off on the accounts. At what point does the ministry intervene to say, guys, we have the ultimate responsibility of ensuring this delivery. You guys are charged with this delivery, but this is a no-no. And that is really what I'm looking for from a governance standpoint between the ministry and the HSA, because it is clear from listening to the CEO, who basically is speaking how hard the finance team is working. But I can tell you, as a finance person, you have $150 million balance sheet, and the auditors tell you to make $105 million worth of adjustment to sign off on it. They have done your work. They have, in essence, done 91% of your work. And now you want to hire another consultant firm to come in to, I guess, get you to a clean audit, fix up your internal controls. At what point do the ministry says we do not have a functioning or a competent finance team? And this is really what I'm trying to get to, because what we don't want is a repeat of this next year. And if you look into 2014, 2015, 2015, 2016, it is a continuing of the same. Now, what I'm going to say is that this is unacceptable and this cannot continue. And it is clear that the people that we have there can't do this work. And to be sitting down and having accounts receivable continue to grow, 53 million growth in accounts receivable in 2 years, when it took you 12 years to accumulate 63 million thereabouts. And in 2 years, you put on 53 million. This is not something that's on the right path. This is not delivery of what it is that the ministry is charged with. And it seems as if, though, the ministry is contented to allow the HSA to continue in this function and be a burden to the Caymanian people. And that, I'm going to tell you, cannot work, cannot continue.
Can you, what does the minister see as the role of the chief medical officer?
Oh, okay.
Oh, I thought it was a statement. I'm sorry.
Sorry, my question is, at what point
Oh, okay.
does the minister
Yeah, I'm
step in
sorry.
and say,
Yeah, you did ask a
yeah,
question.
sorry.
Sorry.
Through you, Mr. Chair. The ministry, when we receive the financials from the Auditor General's office, we note the qualifications, and we do note with concern the qualifications that are there and some of the adjustments that, as you've referred to. We do receive assurances from the Health Services Authority regarding the steps that they're taking to address them. We have been, and the FS mentioned earlier, that we've been, as a government, we've been in a state of catching up on our audits with our financial statements. And it's really only in the last couple of years, I think, that we've really come up to date with them and had some opportunities to see some of the corrections being made and coming to fruition in the financial statements. I believe that my understanding from what I have been advised by the Health Services Authority is that we should start to see, certainly in the current financial year's audit and in the subsequent financial year's audit, that some of these things that we're talking about today are no longer issues and have been addressed. In the case that, if it is the case that we are seeing the same things over and over again going forward, then obviously those are matters of concern, as you've mentioned. In terms of the ministry's role with regards to the competency of the finance cadre at the Health Services Authority, we don't have any operational authority over their staff. It's not a situation where their finance people report to the ministry that we are in a position to manage them. The CEO is the liaison between her team and our ministry. As I mentioned, the ministry's finance team, when we receive the monthly invoices, when we receive the budget requests, there is quite a lot of back and forth between the finance people at the ministry and the finance people at the Health Services Authority. And I know that there's lots of clarifications that are sought and questions that are asked. So I think that, as I said, I think we've been in a catch-up. We've now identified the way forward, and I would expect that in the next financial year's audit, we would start to see these improvements reflected in the financials.
Sorry, through you, Mr. Chairman, and this, what I'm about to say is more directed to the Honorable Financial Secretary and the Accountant General. You guys, or your team, is responsible for creating the EPS, which includes the civil service, which includes the HSA, correct? I just want for you guys to just let me know if you guys are comfortable that you're getting numbers from the HSA, that you're included in government with $105 million type of adjustment on a $115 million balance sheet. If this is something that you guys are comfortable with, then I'm fine.
Thank you, Mr. Member Saunders. Just conferring very quickly with the Accountant General. I think the position from the Minister of Finance is I don't believe we are aware in advance of the level of audit adjustments that Member Saunders just spoke about. I don't believe that we would receive that. We certainly would get the end product, which is the audited financial statements.
But I would assume that this went to the board, and we just amended the law to put representatives from finance and the ministry on the board. Because, and the whole justification given to me on that was that we were putting them there so they could be the watchdogs, because we thought it was necessary to have them on the board in order to make sure we had these necessary controls in place. So you're saying that this has not been presented to the board?
Mr. Chair, the appointment from the Minister of Finance onto the board was only a recent appointment, definitely after the 2015-16 accounts. We'd expect to see something.
This document that he's referring to is dated the 2nd of May 2017. That's certainly after you were put on the board.
It was one of my colleagues that was put on the board. I don't think actually his appointment was.
I mean, don't you agree with the member of the committee that your person on the board should be alarmed about this, and if the reason that you put him there was so that you would have ability to exercise, because I didn't agree with you putting him on to start with, right?
Yes, sir.
But certainly if you put him on, not doing his job, you need to find out why.
Most definitely does cause
well,
alarm.
I can tell you, the reason being is that I am going by the assumption that the board would have been receiving monthly financials, or at least quarterly at the minimum. And if that is the case, they would have received these management accounts prior to the commencement of the audit. And at a minimum, the board would have at least seen some numbers before the audit would have started. So with that said, the question is then the quality of work that was going to the board that you'd have seen at an interim basis, whether it be monthly or quarterly, that by the time you get the end product or the final product comes back, there is $105 million of movement in a $115 million size balance sheet somewhere along the line, whether it flows through the P&L or whatever. So the question is, what reliance can you guys put on your monthly or your quarterly or your interim numbers when these are the levels of adjustments that are being made, and they're not small? And that's really what I'm trying to understand, is the governance of this. Because, gentlemen, what we don't want, and I'm saying this in all honesty, what we don't want is these crazy numbers, because at the end of the day, you guys are tasked with putting all of these numbers together. And when these adjustments come, and I'm going to tell you, it's a big job that you guys have. Well done to you all. But at the end of the day, you also need some comfort that when you're putting numbers together, that they're at least somewhere within the ballpark and not this far out. 2% versus 91%. So that's all I'm saying from a governance standpoint. Thanks.
Mr. Chair, the point is noted, and we completely agree. The only issue we have is because their appointment from the Minister of Finance was a recent appointment, he wouldn't have had the historical knowledge of the monthly accounts to compare. But your point is definitely noted. Yeah, and we will definitely follow it more closely in the future. Thank you for that point.
Chairman and members of the committee, I'm just conscious that one of the big adjustments there was to do with the revaluation, which I was hoping the Accountant General might talk about, of assets, which was a consequence of trying to correct the asset base and get a consistent basis across government to avoid an EPS qualification. So I think if you took the 53 million out, or 55 million, it gets to a smaller amount, but that was yeah, okay.
Half a dozen, 6
But I'm just saying half of it was to do with a cross-government issue about the revaluation of assets that the Accountant General led.
Okay, can you tell me what does the minister see as the role of the CMO, and what is the current role of the CMO at the hospital?
Thank you, Mr. Chair. The Chief Medical Officer role should be the main health policy advisor for the government. It's a role that we actually we're advertising it again this week. We're going to try and recruit again this week. But it's a policy advisor role. It's meant to have some oversight of the healthcare system. It's to make recommendations to the minister and the ministry regarding changes that we might need to make in policies and legislation, identify where there might be some gaps, help us to identify some key performance indicators to track the status of our healthcare system and the delivery. One of the challenges that we have, which was flagged in the Auditor General's report, is around data and knowing, what the status is and how we compare against some other jurisdictions and benchmarks and so on. So the CMO role would be one that would recommend what we might want to be looking at, how we might want to measure it. The CMO is also meant to be the primary liaison between our ministry and some of the international organizations, such as the World Health Organization, Pan American Health Organization, Caribbean Public Health Organization, and so on. we've struggled not having someone in that role full time at the ministry level. It's a capacity gap that we have been trying to address through recruitment. We've been very fortunate that we've had physicians who have filled the role in an acting capacity, but the difficulty for them has always been that because it hasn't been a full-time role for them, they haven't been able to perform all of the duties that come with the role, just because there's only so much that one person can do. So I'm hopeful that with the next recruitment attempt that we are successful and that we'll be able to have that role at the ministry level. And it's not, even though we've had a situation where the acting chief medical officers have been health services authority physicians, the chief medical officer role is not a health services authority role. Historically, the CMO was also the medical director of the hospital, but they now have the separation where the medical director at the health services authority is responsible for the health services authority. The chief medical officer should be sitting up at the ministry in that capacity.
So are you suggesting that if you are successful in recruiting a new CMO, the position will be moved from the HSA into the ministry?
No, because the position isn't currently at the HSA.
Yeah, but I would hazard a guess that all of the same reasons you're given now by the person acting doesn't have the time to do the important role of the CMO, as long as the person remains a physician doing physician duties at the HSA, it's not possible for them to do the role that they need to do.
That's correct. And so what we envision is that they would be full-time at the ministry in that CMO role, and they would retain a much smaller portion of practice as a physician.
But you don't see a conflict in that?
In terms of them maintaining some practice?
Yeah.
I think it's a difficult situation in that, and it's something that we've had a lot of discussions with the various stakeholders about the role and how in a small jurisdiction like we have here, you want somebody who has a feeling, the experience within the healthcare system as a provider. You want them to have an awareness of what is happening on the ground, but you also need to have them spending most, if not almost all of their time in that oversight role. It's something that as the job description is currently drafted, we certainly envision them being at the ministry full-time, but something that we're expecting might need to be addressed when we go through the recruitment in terms of what they might want to do in order to keep their practice up.
What specialty are you advertising to recruit as a CMO?
So the qualifications of the CMO is that you have a master's, in addition to your basic medical qualification, you have a master's in public health and 10 years of experience.
Mr. Chair, through you. When a motion is brought to this House, like a private member's motion, and it is passed and approved, what's the steps? It then comes to you at your ministry?
Mr. Chair, through you, once we're aware of a private member's motion that is...
It comes to this House, it's passed unanimously, then the next step, it comes to you.
That's correct.
Okay. A private member's motion was passed here last year, unanimously. I think, in fact, it may have been brought by the chair. The 2017 revision completely ignored things that were passed. Comparing it to other countries, the laws and regulations are very low standard. Things were in the motion, if I remember correctly, like 3 years experience after board certification. People got to finish their training to board certification level or equivalent thereof. These are some things that are important that were completely left out. Any particular reason why, or this is why we need a CMO in there that can lead you guys that know nothing about medical to put the right thing in these laws? Why were these things left out that was passed in here under 2007 in the 2016 law, and now in the revision 2017 is not there? How can that happen?
Mr. Chair, through you, I'm assuming that the member is referring to the health practice law. Okay. The amendment or the consolidation, I think the 2017 health practice law was really just an updated consolidation. It wasn't the result of an overall review that was done. I am aware of the private member's motion that's being referred to, and my recollection of it was that the undertaking that was given was to look at including those provisions in the overall review of the health practice law when the government undertook that. It hasn't been done yet. So as I said, my recollection of the 2017 revision that you refer to is that it was a legal drafting tidy up exercise. It doesn't reflect a comprehensive review of the legislation that was done. So it's not the situation that the private member's motion has been ignored in creating or as part of an overall review. The review has not yet occurred. It is scheduled to occur, and that private member's motion is part of the information that will be fed into it for consideration.
So the ministry doesn't see the urgency in having doctors and specialists whose first language is not English do an English test, but we currently require it for a gardener and a plumber and an electrician, but we can get a cardiac surgeon who can come here. English is not the first language, but they don't have to do an English test.
Mr. Chair, no, that's not what I'm saying at all. The requirement for an English language test is an existing requirement at the discretion of the relevant registering council. One of the, and I don't have my legislation in front of me today, but one of the requirements that the councils have to consider when reviewing an application for registration of a practitioner is that they have sufficient knowledge of English. That is one of the requirements that has been in the legislation for some time. And if I remember, and I don't, again, have it in front of me today, the private member's motion spoke to setting in stone in the regulations what the benchmark would be to make that determination in terms of the English language capability. That's something that the individual councils have the discretion to put in their guidelines now and have done so. And it is something that I know that they have been applying, because I'm aware of a couple of instances that applications have not been approved on the basis of inadequate performance on an English language test. So it isn't the situation that we don't think it's important. It's important enough that it is in the legislation, the requirement to have the command of the English language. It's in there now.
But in a subjective way, if you don't have any standards, it's not an objective assessment, and you don't have to have a passing grade. It's just something that if they feel like it's okay, if they feel like doing it, they do it. If they don't feel like doing it, they don't do it. What happens if they don't do it? Who's accepting the liability?
Mr. Chair, it is currently at the discretion of the individual council in terms of how they satisfy themselves regarding the various criteria for registration, for applications for registration. Some of the councils have issued guidelines or have put guidelines forward that have outlined for applicants what the expectations are in terms of the different criteria that need to be satisfied. So one of the discussions that we need to look at, and something that we've been having discussions about in keeping with the private member's motion, was whether we want to legislate that, whether it's something that needs to be detailed in the regulations, or whether it's sufficient to require that the councils have those established and gazetted in order to review the applications.
And you're comfortable with the existing situation? When does the minister plan to review the law in its entirety?
Mr. Chair, that would be probably toward the middle of next year, after we've done the review of the national health policy, so that we can make sure that we have that in line.
And the minister is not concerned with the expansion beyond the legislated countries from which we accept registration. Now that has been expanded, the minister does not believe that should have an impact and increase the urgency of having a proper, objective, standardized test.
Mr. Chair, there has been quite a bit of discussion since the amendments were put in place to create the category of institutional registration, which is what you're referring to allow the registration of practitioners from jurisdictions other than the 7 that are recognized for the principal list. As part of those amendments, some requirements were put in place regarding how the councils can go about satisfying themselves with regards to the educational qualifications of the practitioners, the work experience, the knowledge of English, and so on. All of the applications for registration for that category are required to tick the same boxes in terms of satisfying the councils before they can be registered. So one of the challenges I think that the councils have had is because what we have done historically with the 7 jurisdictions that we recognize for principal list registration is we basically said, if you have gone through their exam system, if you've passed whatever registration requirements they have, we believe that that is good enough for us. We're satisfied if you've satisfied them. We don't have a local examining board. We don't have a local framework set up to make those assessments. We have relied on CAMC, the Caribbean Medical Council exams for some of the registrations as well. So one of the challenges that I think the councils have had is determining, particularly with regards to the educational qualifications, with the countries that they're not familiar with because we haven't dealt with them. The guidelines that were gazetted by Cabinet in May 2013, I believe it was, May or June, outlined some of those guidelines that the councils are to use, and those are another thing that we are going to have to look at. Now that we have the benefit of a few years of practice with the framework that we have, the guidelines that we have, and the experience of the various councils in registering these practitioners, and the experience of having these practitioners here practicing, I think we're in a better position now to make an informed amendment going forward to see if we need to look at eliminating some of these categories of registration, adding some countries to the list for principal registration, staying with what we have, and so on. So that's something that we're going to be looking at as part of the overall review.
So the ministry is not concerned in changing members of the licensing authority, that they may be more lenient, particularly for with the command of English, since there is no standard established. It's a very subjective thing.
Mr. Chair, the changes to the various councils are cabinet decisions that
That's the problem.
cabinet has made, and
The
they
political
have
appointments.
And I believe, and I don't have the lists in front of me, but I believe that there has been continuity. I don't think that there's been a change that we've changed a board wholesale. But again, I'm speaking from memory and not from paper in front of me, and I don't know for certain, but certainly a recommendation from the ministry when appointments are being considered is to make sure that there is some continuity for that very reason, to ensure that there's some consistency from one to the next as those appointments are being made.
Mr. Chair, through you, the Cayman Medical and Dental Board, I think that's the right name for them, the one that approves license and things like that.
Medical and Dental Council.
Correct, Medical Dental Council. They're supposed to be independent. Is that correct? They're an independent body that has their own regulations and things. They should not be interfered with or try to be influenced by the ministry or by us. Is that correct?
Through you, Mr. Chair, the registering councils are set up under statute, under the health practice law, the health practice regulations. Again, I don't have my laws in front of me, but I believe that there are sections of the legislation that speak to, should the minister be minded to issue a directive to the councils, how they would be able to go about doing that. There are some controls around it, but I don't have the legislation in front of me, so I can't point you to a chapter and verse of it that speaks to it.
Okay. Has the ministry, has your ministry or yourself or anyone there tried to have an interference or interfere with the board at any time? Or has the minister ever given you a directive to give them, like you just said, that there may be a clause in there? Forget the clause that is there. Outside of that, has the ministry or yourself or anyone in there ever tried to influence or interfere with this board?
Through you, Mr. Chair, not that I'm aware of.
Thank you very much, Mr. Chairman. That's all for me.
Another question? Thank you very much, Mr. Ahern, for coming. We need to have a short admin meeting afterwards. Right here. And the rest of them leave. Not on them.